that it? No. Okay, guys, good morning. So much to turn on here. How is everybody today? This is the halfway point. Isn't that crazy? You are half done after today. Oops. We have a lot of stuff to go over today. So before we get started, let me go ahead and get your scores for chapter 4. Okay. If you don't have it, just say pass. So this will be for chapter 4. You read chapter 4 in the yellow book, took the test on page 184, and then graded it. This is your grading scale. If you want to just tell me how many you missed, I'll do the conversion for you. Isabella, Kiana, Julia, Jay, Erica, Sophia, Victoria, Christine, Desliana, Cleanta, thank you, Autumn, thank you, Chloe, thank you, Adriana, Thomas, thank you, Lisette. Lisette, do you have 2 and 3 for me? For both? Okay. Thank you, Janae. Thank you, Jamar. Chapter 4, yeah. That's fine. Celeste. Okay. Did I get everybody? Okay. Yeah, it's a little more technical. A lot of terms there. Yeah. Any that you want me to explain to you? Any in particular that you want me to go over? I feel like I just gotta learn. Flashcards will help. Chapter 4 is a little bit technical. It's going over anatomy and physiology. So how is our body made up and how does it work? And we're actually going to go over that a little bit today, just a very brief review. As CNAs, this really isn't in your scope of practice, okay? We don't diagnose, we don't treat. We're providing support services for the team members that do that. So it's not, good morning. So it's not going to be featured on the test really heavy because it's not really what you do. But you do need to have at least a working knowledge of the vocabulary because when you're working with nurses, they're going to be using those terms. So you do need to know what those terms mean just because of the environment that you're going to be in. Those of you that go on for nursing, you're going to have an entire year of anatomy and physiology before you even get into the nursing program. So it starts you out at a cellular level and builds from there. It's for nursing, this is pretty intensive. So you get an entire year of anatomy and physiology and then get into nursing and they're going to apply that knowledge to different conditions. Okay, good. Any terms? Anybody come up with a term you need me to help you with? Sputum. Sputum is a secretion that's in the lungs. And when you cough, have you ever coughed up stuff, like green or white or rust colored? If you have a cold and you cough stuff up, well, that thick stuff is sputum. Okay. That's sputum. And CNAs often will be asked to get a sputum sample from patients. Usually this is first thing in the morning, because when we lay down, all those secretions kind of accumulate. You get up in the morning and you cough a lot when you're sick, and that's usually when you bring stuff up. So we need to know that, because as CNAs, we get patients up and help them with bathing and dressing and grooming and toileting and all the morning activities that we do. So it's not uncommon for CNAs to be asked, hey, when you're doing AM care, can you get me a sputum sample? So as they're coughing, you just ask them to cough some up into a container. We collect it. Mucus and sputum, yep, same thing. Mucus is a little bit more non-specific term, because you can have mucus in a lot of different places. We tend to think of it in the respiratory system, but you can have mucus from the nose. That's not sputum. Sputum comes specifically from the lungs. Okay, good. Any others?
I don't know how to pronounce this one, but
Yep. We're going to actually go over that right now. It's the integumentary system. Integumentary system. And it's one of the body systems in the body. So let's go over that. So here are the body systems. Let's see here. Oh, wow. Let's wish this person some good luck. Franzo is going to have the skills exam today. So best of luck to you. Yeah, best of luck. All right. So we have these different body systems, and each one of them does a different job. Okay. So each one of these body systems has a specific purpose. So we need to be aware of the body systems. We need to be aware of the purpose of each body system. And we also need to be aware of what happens to those body systems as we age, because there are changes in every body system that come along with aging. Now, the integumentary one, we actually talked about a little bit. The integumentary system is skin, hair, and nails. So we talked about the changes of aging in the skin. Remember how the fat layer gets resorbed and the skin is going to get thinner? That means the patient is more prone to injury, because the skin is thinner and doesn't have as much cushion. So we've talked a little bit about that, but let's go through each one of these individually. And we're going to do this very, very quickly. So you may want to go back and review this video later, because we got a ton of stuff to go through today. So I'm not going to spend a whole lot of time on this. It'll just be a really quick review. So the nervous system is where we're going to start, because the nervous system controls everything else. It is the control center of the body. Your nervous system is made up of your brain, your spinal cord, and your nerves. And it's going to control all body processes. Think of it like command central. Okay. So every other body system is going to be told what to do by the nervous system. So if we have a condition that affects the nervous system, it's going to affect every system in the body. Does that make sense? Good. Okay. So some signs of aging we would see with the nervous system is diminished senses. So I want you to think of the body, the human body, like a factory. If I were to invent this thingamajig, right? I'm inventing this. When I invent it, I have to have somebody make it. So I go tour a couple of factories. The first factory I tour is brand new, state of the art. Everything is electronic, works super well, high quality stuff. It's amazing, right? Fully automated. And the second factory that I go look at is about 80 years old, crumbling, broken down. No maintenance has been done, so the gears are all rusty and missing teeth, and it's only going to work some of the time. Which factory do you think I want? Brand new one, right? Why? Why would I want the brand new one? Okay, more efficient, better quality that's being produced, right? And more consistent. Your body is a factory. It's actually a whole bunch of little tiny factories inside one big one. As you age, your body is also going to age. Each one of those factories is going to age. So your brain is a memory making factory. So the memories that your brain made when it was brand new, shiny, new, right? Those are going to be really good quality memories. They're going to stick around for a very long time because they were made in a factory that was brand new. As we age, we get into our 80s and 90s, that factory is 80 or 90 years old. Do you think it's going to make the same quality of memories? No, this is why we can have an older person that can't remember they had lunch 15 minutes ago, but remembers what shoes they wore to a piano recital when they were 12. Like, that's totally useless information for them, but they still have that memory. And it's because the memory was made by a new factory. It was a good quality memory. Does that make sense? This is why a lot of your older patients will ask you the same question over and over and over again. You give them the answer, but their memory storage is offline right now. You can give them the answer over and over. It's not going to set in. So they're going to ask you again, what time's lunch? It's at noon. What time's lunch? I just told you it's at noon. What time's lunch? We have to understand that our patient isn't being difficult. Their brain is not able to set that memory at that time. Make sense? But that's not the only thing that's affected in the brain. All of our senses, sight, smell, hearing, touch, taste, all of those are going to be affected as well. So foods that your patient used to absolutely love, they may have no interest in anymore. Or you may be talking to the patient, but not facing them, and they have no idea what you said because their hearing isn't as acute as it was. Or they may need lights on in the room when they're walking around instead of just a small night light because their vision isn't as good as it was. Remember, all of these body parts age with the body. We tend to forget that. We just see an old person and we think, yeah, the person is old, but we don't really think about all of the little parts that make up that person and how those things are aging. And that's what this is all about. Make sense? Okay. Another thing that's going to slow down our reflexes. Now, this might be setting our patient up for a safety problem. If our reflexes, think about reflexes. What are reflexes there for? Reflexes are there to keep you safe. If you touch something hot, a reflex is going to pull your hand away before your brain is ever engaged, right? If you start to trip, your reflexes are going to try to right you before you fall. Reflexes are there to keep you safe. Well, if our reflexes are aging, we have an opportunity for more injury. Make sense? Okay. Decreased concentration, sure. Decreased coordination. Remember, the brain controls everything, including your muscles. So having a nervous system that's aging can actually impact our patient in a safety way. So keep that in mind. Now, this is just aging. Add on to this add on to this. Maybe a condition that affects the nervous system, like Parkinson's. Okay. So if we just have a nervous system that's aging, that's bad enough. We got all this going on. But you add a condition on, like Parkinson's or a stroke or dementia or something like that. And all of these effects are going to be amplified. Does that make sense? Good. All right. Then we have the cardiovascular system. Now, the cardiovascular system, let me go back here. Hold on. The cardiovascular system is made up of the heart, the blood vessels, and the cells. Whoops. No, I wanted to go this way. All right. There we go. All right. It's made up of the heart, the blood vessels, and associated structures. And as it ages, like every other muscle in the body, it's going to get weaker. Now, your heart is a muscle. So if the muscle gets weaker, it's not going to pump blood as efficiently, which means that areas of the body may not get good blood that it needs to heal. So injuries may take a little bit longer to heal. Circulation can be affected. If you have to rush somewhere, let's say we have to go to the bathroom, we're trying to get there, right? That takes more blood flow. Well, we may not be able to accommodate that. We might get out of breath quicker or tire quicker. So your heart muscle being weaker can affect your overall endurance and exercise ability. Think about all the things that we do on a daily basis that require movement. And you can see how by the end of the day, your patient might just be too tired to do anything more. Okay. We also end up with higher blood pressures. We're going to talk about that a little bit later today. I'll explain how that happens. But as we age, our blood pressures tend to go a little bit higher. Prolonged bleeding is very common because our platelets just don't do the job they used to do. And fragile vessels throughout the body. So you end up with bruising. Have you ever seen an older person's arm that has these big red blotches on it? Yeah, that's because there was bleeding. Like maybe they hit their arm against a table or something. Those capillaries started bleeding. And because the platelets weren't there to stop the bleeding, it just kept going and created this big red blotch. It's just blood under the skin that escaped from the vessels where it should be. We have the respiratory system. Respiratory system is your lungs and your bronchi, your trachea, your pharynx, or back of the nose area. This is where we breathe. This is how we get oxygen in and how we get rid of carbon dioxide. And that's something that a lot of people don't really understand. We think we breathe in for oxygen. And we do, but that's not nearly as important as breathing out carbon dioxide. Carbon dioxide built up will kill you. So that's actually the more important reason for breathing. And that's what makes smoking so dangerous when you smoke, is because you're training your body that carbon dioxide isn't so bad. And it will damage all of those structures as well as the rest of the cells in your body. This is why it promotes cancer development. So breathing out carbon dioxide is very, very important. Well, as we age, all of this is elastic, right? Your lungs have to be able to expand to take in air and contract to push the air out. It's controlled by the diaphragm, which is a muscle below the lungs. As we age, our muscles tend to get weaker, less elastic, less bendy. So we can't inhale as much. We can't exhale as much. And you'll hear older people often say, I feel like I can't get my breath out. It's like it's trapped inside. And that's because of that lessening of elasticity. Good? Make sense? Okay. Less endurance. Oh, that's very common as we get older. Again, we've got to have the oxygen to give to the circulatory system to push around the body. If this isn't working right, then the circulatory system doesn't have enough oxygen to spread around and we get decreased endurance. Okay. Shortness of breath, very common. We have the endocrine system. The endocrine system is made up of lots and lots and lots of different organs. These are all hormone producing organs. We tend to think of hormones as adolescent things. Hormones are way, way more. We took 2 hormones, we made them the poster child for all hormones in the body. And that is, you know, they play like a role in this much of your life, right? There's a lot of other hormones that play way bigger roles in your life, like insulin. Insulin is a hormone that controls how much glucose can enter the cells. Thyroid is a hormone that determines whether you have any energy, determines how your body processes things. There are thousands of different hormones, and they're all made in different areas of the body by your endocrine system. But don't think that hormones are just related to estrogen and testosterone. That's just like this much of the hormone production in your body. I'm not sure why. They had really good PR. Man, I don't know why those two got such a huge market share of endocrine press. And hormones are probably the most important part of your body. Although the brain controls everything, the heart pumps to move around blood, your lungs inflate and deflate to bring in oxygen and get rid of carbon dioxide. Without hormones, nothing works. Nothing works. They're kind of the little chemical messengers in the body. Nothing works. So as we age, this whole thing starts to break down. So we end up with less insulin, and that can predispose us to diabetes later in life. We end up with fewer thyroid hormones, which affects our metabolism. It also will affect how cold we feel. Oh, wait, we've already talked about that, right? So not only do we have a lack of fat to help keep us warm, keep our body heat in, we got these hormone things going away, which makes us feel cold. That's why grandma's house is 83. Okay, so good. You got pituitary hormones. You got lots and lots of different adrenal hormones. You got lots of different hormones throughout the body, and they're all going to be somehow affected by age just because it's aging. Then we have the urinary system. This one's pretty self-explanatory. Most people know how this works, right? You feel like you got to pee, you go to the bathroom and you pee. But this whole system is also affected by aging. Our kidneys don't filter blood as well as they used to. So your blood when you're little is squeaky clean, man. Those kidneys do a great job. They get rid of everything that doesn't belong. But as we age, those kidneys don't work the way they used to. So we got our blood's a little bit not dirtier, but it's not as clean as it was. It didn't remove as many waste products. So we end up with electrolyte imbalances, potential for dehydration, inability to eliminate completely, feeling like you always have to go to the bathroom. I just went 20 minutes ago. I got to go again. So these are very, very common signs of aging. And then we go on to the integumentary system, which is what we were talking about before. This is skin, hair, and nails. We've got a lot of changes in the skin. We've talked about most of those. We've also talked about changes in the nails. Remember, they become more brittle as we age. That's why we have to file in one direction only. Hair tends to become a little more brittle. It doesn't grow as fast. Generally, it will change color. It loses a lot of its pigment. and it'll turn either gray or white in some cases. And that's just because the hair follicles that control the pigment, it just not working real well. Okay, make sense? You can also, we talked about the decrease in subcutaneous fat, but we also have this. Now, this, I always thought it was kind of funny that the hair stops making color, but the skin starts making color. It's like, can't you just kind of move that over there? Because you'll end up with these dark blotches on the skin that were never there. It's like I had, you know, like, well, I'm getting some. So if you look at my arm here, I don't know if you can see it. I got this, that was a freckle for the longest time. Now it's morphing into this blob, right? So I'm getting this darker blob that's kind of spreading. It's not a mole. It's flat. It's kind of like a freckle that kind of went crazy. And that's what happens. We end up with these bigger areas of pigment on the skin. Okay, so we lose pigment here, but gain pigment here. Somebody needs to reroute that. If you can figure out how, you'll make a fortune. We have the reproductive system. Of course, that is going to be affected by aging as well because it is controlled by hormones. We just talked about hormones and the endocrine system. So because all hormones are affected as we age, of course, reproductive hormones are going to be affected as well. And you've got a lot of effects of this as we age. We can end up with hot flashes and night sweats, decreased moisture production, of course, erectile dysfunction, which the pharmaceutical industry is making a killing on. External skin can become thinner and drier, and decreased fertility. So generally speaking, when a woman goes into perimenopause or the time around menopause, she is no longer childbearing. The hormones just aren't there to make childbearing possible. Now, men, however, do retain the ability to impregnate a female, but it's still diminished, okay? So the sperm that control that, of course, they're like every other part of the body, are aging, so they're not as effective. So reproduction can be affected. Gastrointestinal system, this is where you'll hear the most complaints from patients, well, outside of arthritis, because people really get upset that they can't eat the foods they used to eat. I love pizza. I can't eat it anymore because I'm getting older. Or I love garlic. I used to use garlic all the time. I can't tolerate it anymore. Patients usually eat very small meals because their stomachs are smaller. There's not enough room. So where you used to eat a whole plate of food at dinner time, now you might only eat maybe a sandwich plate full. A lot of times the bigger meals are eaten earlier in the day. So the midday meal is usually a bigger meal. And then at night, they just have something small to hold them over. And that's because of delayed gastric emptying. The food just doesn't move through the digestion system the way it used to. So smaller meals, heavier meals earlier in the day. We end up with diminished nutrient absorption. So we don't process the food. We don't take as much nutrients out of the food as we used to. And we usually recommend a multivitamin as we get older. Esophagus muscle tone diminishes. I want to talk about this. Have you ever taken a drink and it went down the wrong pipe? Okay. Yeah. So that's when you're young, distressing. When you're old, normal, common. Because in order for fluid to go down your esophagus, you have to swallow. It's a physical action. It's a muscular action. But muscles tend to weaken as we get older. So that swallowing isn't as effective. So then we end up with a little bit of liquid that kind of drips down the front tube, which is the trachea, going into the lungs. So diminished esophageal muscle strength can lead to swallowing difficulties. If you're feeding a patient or if you're in the dining room and notice a patient coughing a lot while they're eating, you need to let the nurse know, because that is an aspiration risk. Okay, so if somebody is coughing a lot while they're eating or drinking, the nurse needs to know. Remember, we talked about everything the nurse knows, or the nurse should know, and everything should be reported no matter how minor you think it is. Do you guys remember that? This is one of those, because you won't understand the significance of everything that you're seeing. But it's important that you pass it on. Okay? Constipation, very, very common because everything is slowing down. But this is the one I want to talk to you about. Decreased hunger and thirst reflexes. As you age, it's not uncommon to not feel thirsty. So remember, it's super hot. Lots of humidity here. We've got somebody who maybe is afraid of coughing while they're drinking. And they're, remember the neurological changes of aging. We may have decreased senses, right? So the thirst is a thirst reflex. So that gets diminished with age. We have fewer thirst prompts, and we're in an environment that leads us at risk of dehydration. So dehydration in the elderly is a super common occurrence, super common. And we have the ability to stop that, because dehydration kills. It kills. We tend to think of dehydration as no big deal. You go into the hospital, get a little IV fluid, you'll be fine. And that's not how that works. So as we age, dehydration becomes much, much more serious, way more serious, because it's really hard, because the kidneys aren't working right. That's what controls all the electrolytes exiting the body. So all of these systems get together, not enough fluid, and the kidneys start to shut down. And now we're trying to support the kidneys, and this whole cascade effect happens. And dehydration can kill the elderly. So if you have a patient that you know isn't drinking, and you'll know, you're the ones filling the water cups. If you go in and you fill a water cup and you leave it on her table and you come back 2 hours later and it hasn't been touched, are they drinking? No. So you'll know. You need to let the nurse know, but you also need to encourage the patient. Me, every time I'm in an elderly person's room, I ask them to take a drink. Hey, Margaret, can you take a quick drink for me? Let's keep that dehydration away. Just take a quick sip for me. I know you're not thirsty. Just do it for me. Because I know that their reflexes may not be triggering them to drink. We have the musculoskeletal system. This is the one, this is probably the body system you're most familiar with. It's the muscles and the bones. It's what gives us mobility. That is affected in the body for sure. Bones become more brittle, muscles become stiffer, harder to move. We get less bendy as we get older. You can end up with inflammation of the joints. Boy, I'm there now. And it is painful. Yep. Instability and coordination impairments are very, very common. So this is why we often walk patients to the bathroom or to the dining room or whatever. It's because as we age, we just become more prone to injury. We have decreased coordination, decreased reflexes to right ourselves if we start to fall. So the propensity to injury is much greater. Then we have the lymphatic system. Now, this is kind of the redheaded stepchild of all the body systems. Nobody really thinks about the lymphatic system. This is how we recycle fluid in the body. Have you ever stood up so long that your legs started to swell? that ever happen? Yeah, most of you guys are young. You haven't realized that yet. As you get older, you will. And that's because of gravity. Gravity's pulling all that fluid down. Well, we've got to have a way of getting it back where it needs to go, into the circulation system. And that's what the lymphatic system does. It collects all that excess fluid that's in places it shouldn't be, cleans it up. So the lymphatic system is part of your immune system. So it cleans that fluid and puts it back into circulation. Your lymph system is very, very important in the body. And again, it will be affected by aging. And that leads us to develop swelling, tired, achy muscles because of the excess fluid. But it also can affect our ability to fight off infections. So decreased immune system. Any questions on those?
Is that what compression socks do?
Yes, absolutely. That is exactly.
I know that nurses wear those too because they walk a lot. I guess.
Right. If you're upright, think about gravity, right? Gravity's pulling everything down to the center of the earth. So if you're standing up, let's go back here. If you're standing up, right, gravity's trying to pull everything in your body down through your feet. It's just pulling everything down. Well, one of the things it's going to pull is fluid. So if you're standing up and walking for 12 hours a day, walk, and that's what we do, right? We stand up and move. During that 12 hours, you're not sitting down. You're not putting your feet up. There's no rest there. So all of that fluid just keeps getting pulled down. So by the end of the day, it's not uncommon to have swollen feet or swollen legs just because of the fluid shift, because of gravity. Okay. So nurses, waitresses, anybody that's on their feet for extended periods, compression socks help because, again, gravity, okay? Gravity's pulling everything down. Well, in order for that fluid to get back to your heart, it's got to go up. It has to fight gravity. That's hard work. So in your veins, particularly your leg veins, inside the veins, we're going to get to this in a future lesson, but in your leg veins, you have little valves on the inside of the veins that make little kind of like sections of a ladder, okay, little chambers. So as your heart beats, it pushes this blood up into this chamber, and then the valves close to trap it there. And then the heart beats again, and it pushes the blood up into the next chamber, and the valves close. And then up into the next chamber, and the valves close. And up into the next chamber, and the valves close. Make sense? Okay. Well, as we age, what do you think happens to those valves? They get weak. So they don't work as well. And this is why we get swelling in our legs. But that compression helps hold everything in, right? It's literally compression from the outside in, and it supports those vessels so the valves work better. The earlier you start wearing compression socks, the more effective they will be. If you wait until you're older and you've got swelling all the time, compression socks will help, but they're not going to prevent further damage. If you start early, you can prevent that damage from occurring. Good? Make sense? All right. So to review pulse, we're always going to support the arm. Pulse is always reported over 1 minute. We're going to follow the care plan for how long to count. Normal is 60 to 100. We're going to use the fingertips, not the flat areas of our fingers. We're not going to use our thumb. Radial pulse is located on the thumb side of the wrist at the bendy parts. For the test with the evaluators, we're going to say start and stop for timing. With Florida, we count with 2 evaluators, and we make sure that we document at the end of the skill. Dressing a resident, we're going to ask about their clothing preference before we undress them. Get their clothing before we undress them. We lift from below, supporting all joints when lifting. We undress the strong arm first and dress the weak arm first. We don't overextend or force movement. You want to adjust the clothing for neatness and appearance, and the call light is going to go in their stronger hand. For hand and nail care, we're going to wash whatever the care plan tells us to. So for the test, it's just one hand. We're going to support the wrist and arm at all times. We'll soak the hand in water. So put it in water, we take it out to wash, we put it back into rinse and take it out to dry. Anytime we take it out, it should be on a towel. We're going to clean underneath each nail, wiping it off in between nails, and then file the rough edges in one direction only. We're going to warm up the lotion, put it on, and then wipe off the excess. Okay. We apply lotion last. When we make an occupied bed, remember that clean rolls toward you, dirty rolls away. So we're going to make the bed a half at a time. A half at a time. Patients should always be in the middle of the bed. Doesn't matter whether on their back or on their side, middle of the bed at all times. So when we put the sheet on, we'll secure the corners, roll it toward us, tuck it underneath the dirty, and try to minimize wrinkles because wrinkles lead to bed sores. Okay. We want to remain behind the patient's behind, smooth any wrinkles out. We'll make some hospital corners. We're going to loosen the sheet over the toes and replace the pillowcase with the opening facing away from the door. Range of motion. Remember that CNAs do exercises to retain function. We're not trying to make anything better here. We always support the extremities from below with a flat palm when we lift. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. We'll follow the care plan to know which body part and how many repetitions. You want to monitor for pain. Okay. Remember to return all the way to the start position. So if I'm doing flexion extension and I come up, if I come down to here, that is not a full range of motion. If I do this, I have to come all the way back to start. Okay. All right. Look how much you've learned. Questions? Everybody good? Ready to move on? All right. So let's go to page 138. Okay, when you look at page 138, let's see here. All right, so there's a couple comments here I want to get to because they are relevant. Let me go back up here. Okay, so Kanisha says, good morning, Miss Patty. I called Prometric yesterday and they told me that I have to do the whole test over again because my time to take the written exam was up on May 18th. Okay. So let me talk to you guys about this real quick. We're going to go through the test registration process at the end of class today. When you register, if you don't get an email back from Prometric within about 7 days, you need to contact them. So you're going to get 2 different emails. Actually, you get 3 from Prometric. One when you create your account. That just confirms your email. The second one it should come within 3 days, but give them 7 just to make sure. The second email will say, we've got your application. It's complete. It's good. We're going to forward this to the Board of Nursing now to prepare you or to approve you for testing. Good? Make sense? The third email that you get from Prometric says you've been approved for testing. Here is your test date. You have to check your spam folders and promotional folders, especially if you have an iCloud or Yahoo email address. iCloud and Yahoo moves everything to spam and promotions. They have the strictest email filters. So chances are you're going to miss your test. And that's what happened with Kenesha here, is that unfortunately she missed her test date, or because she didn't get the email, or she didn't register. I'm not, maybe she failed it on the first try and had to register to do it again. I don't know. But you have to pass both sections within 2 years in order to be certified. So let's say that you pass the written, but you failed the skills. You have to retake the skills. That written test will stand. It'll be okay. It'll stay there for 2 years. So you have to pass both sections in that 2-year time frame. So I don't know, either she didn't register for the written after failing it the first time, and her time ran out, or she didn't get her email about her test date and missed it. They do not give refunds, guys. You've got to stay on top of that. Okay. All right. And Kenesha, how do you study for the written exam again? Let me give you, this is the ebook. See here, sorry for being late. Your time is different. It's 6 a.m. here in Arizona. Oh, that's early. Get a cup of coffee. And can you add caption to your videos when live? I'll look into that. I don't know how to do that while I'm live. I know that there's automatic captions that can be done for pre-recorded, but I don't know how to do that when I'm live. But I will look into that. That's a good idea. All right. So get rid of that. All right. So let's get back to side lying position. So when we're going to change a person's position, these are the principles that are going to be involved. And of course, here they are all spelled out for you. We're going to follow the care plan. We always do the opening. We evaluate if we need gloves. We'll use a barrier because we have supplies. We're going to use a privacy blanket because our patient will be uncovered. Linen rules apply, so don't hold anything against you. Scoot and roll, we talked about briefly on Monday. We're going to get into it a little bit more today. And then the closing, of course. These are our skill-specific steps. I do have a video for this. Along the bottom, you'll see test-specific information. Guys, all we're doing here is turning a patient onto their side and using some pillows to keep them there. They're going to give us 8 minutes to get that done. Way more time than you need. You're turning somebody over. Okay. So don't get in a rush to do this. Don't rush through this. So let's talk about scoot and roll. We talked very briefly about this in class on Monday, but we're going to go through each one of these steps in detail right now. And this is a topic that I really want to make sure that you truly understand. So if you go to page 139, you'll see all of our step-by-step instructions. Care plan is at the top. Supplies are at the bottom. This care plan tells us to position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. So we talked about this on Monday. Remember that side rails is just like a crib. Same method, same action, same intent. The problem is that this is a baby. This is an adult. Babies don't stay in cribs. What makes you think an adult will? So if you put side rails up on an adult's bed, and they don't want to stay in bed, you've just created an obstacle for them. You've increased the likelihood that they will fall or become injured. And remember, our older patients have decreased coordination, decreased reflexes, more prone to injury, right? We got a lot of things stacked against us. We don't need to add an obstacle on top of all of that. So side rails cannot be used in the name of safety. Positioning rails, however, are not side rails. Positioning rails are half rails at the very top of the bed, and it still allows the patient to get out of bed because the bottom is open and able to be moved through easily. So these half rails are not side rails. They can be used. But bottom rails on the bed probably aren't even going to be there. Most settings have taken them completely off of the bed. If you get an order for side rails, usually maintenance has to come put them on. We don't even have them there because we don't trust you. Because way too many CNAs have put side rails up trying to get away with something. Make sense? There's a nursing home here in Florida. Yeah, I know, Florida. This is a night shift, night crew. And they put all of the patients in bed at the beginning of the shift, put all the side rails up in the entire place, and gave everybody Benadryl. Every time this crew worked together, they called it the easy shift. Now, I want to stop and talk about that for a second. Yeah, it probably was an easy shift, right? The patients are all sleeping. They're in beds with their side rails up, and the staff's in the break room playing poker. Nice shift. But let's think about this from the patient's point of view for a second. Do you think every single one of those patients wanted to go to bed? No. So when you're in a nursing home, do you guys know who pays for that? What's that? Yeah, the patient. Do you know how much nursing home care is? It's about $9,000 a month. $9,000 a month. So they have to pay for that out of their own pocket. That means they had to sell their house, guys. You probably don't have $9,000 a month in your budget. In order for them to afford the nursing care they need, most of them have to sell their home and all of their possessions. So they've sold everything to move into this nursing home, and they're paying $9,000 a month to be drugged and restrained. How horrible is that? We can't trust that people are going to do the right thing. So that's why you won't see side rails on the bed very often. And if you do, please make sure nobody's using them illegally. If you think that somebody is, please report it. Because if my grandmother is in a nursing home and paying $9,000 a month to be cared for, I want her to receive $9,000 a month care. Okay? Remember, in healthcare, it is not about you. Yeah, that one really got under my skin. So let's talk about immobile patients for a second. So just because somebody is in bed doesn't mean they're immobile, right? Somebody right after a knee surgery is going to be in bed. That doesn't mean they're immobile. Somebody that just had abdominal surgery is going to be in bed. They haven't gotten up and walked around yet, but they're not immobile. Immobile means unable to move on their own. Unable to move on their own. Just because somebody's in bed doesn't mean that they're unable to move on their own. Do you guys understand the difference there? Okay. Now, immobile patients will probably be in bed, but not all patients in bed are immobile. So we have to start thinking about things in a little bit less general terms and understand that every person is an individual. So let's talk a little bit about what immobility actually is. So immobility is an inability to move on your own. Now, it could be because you are paralyzed. It could be because you have dementia. It could be because you have a progressive muscular disease, like muscular dystrophy or ALS or myasthenia gravis or something like that. It could be from a progressive neurological disease like multiple sclerosis or end-stage Parkinson's. So there's a couple of different reasons that we might be immobile. But if we are, then we have to start to think about how that affects the body and how we can mitigate those effects. So that's what we're going to talk about now. Somebody that's immobile won't be able to do anything on their own. They're going to require us. Now, immobility has a lot of really bad effects in the body. It's going to slow digestion down because when you eat food and it goes through your intestines, it's going to go through the small intestines, then the big intestines. Well, the problem is that those intestines are what we call smooth muscle. They don't move on their own. They don't move on their own. So in order for food to move through your digestion system, it relies on your abdominal muscles from you moving around to move the food through. Well, if we've got somebody who can't move, that food isn't going to get moved through their digestion system very well, which means we can end up with constipation. We can end up with ulcers and polyps because the food is just sitting there rotting. We can end up with perforations. We can end up with all kinds of really, really bad things. So turning a patient is going to help with their digestion. But wait, there's more. It also reduces lung volume. Remember, your lungs have to be elastic to expand and contract. Well, as those secretions just kind of lay in there, if we're not moving that patient around, that secretions lay in there, they get hard. Now, those lungs aren't going to expand and contract. So now we've got an oxygen problem with our immobile patients. Decreased bone density. Now, how does this work? Well, your bones actually look, if you took a bone and put it under a microscope, it's not solid. We think it is, like we look at chicken bones and rib bones when we go to Sonny's and steak bones, right? They look solid, don't they? But if you looked at it under a microscope, you would see that it's actually full of all kinds of little holes. It looks more like a sponge. Okay, so if you looked at bone under a microscope, it looks a little bit more like a sponge with all kinds of little gaps and holes. And this is actually to make the bones a little bit lighter so it's easier for us to move around. Well, as we are immobile, those holes get bigger and bigger and bigger because the body mines the calcium and phosphorus out of those bones. Your body actually breaks the bones down to get the calcium and phosphorus it needs for muscle and heart conduction problems, because calcium and phosphorus are actually produced through movement, optimized through movement. Muscle atrophy, our muscles just shrink. We know this, right? If we spend our lives on the couch watching Netflix, your muscles are going to get weak because you're not using them. So muscle atrophy, we know that one. It also decreases our immune response. It makes us more susceptible to infection. Well, wait a minute. We got an immobile patient. And where are they? In bed. Where is the bed? Yeah, in a setting full of pathogens, and we have it decreased immune function. So they are at higher risk. Everybody's at high risk, but these guys are like DEFCON 4 or 1. What's the worst one? DEFCON 1? I don't know. These guys are at risk, okay? It also affects cognitive function because your brain needs activity to prompt those neurotransmitters. And remember I was talking about endocrine system a little while ago, all those hormones and how they're the messengers of the body? Well, your brain produces a lot of those. And if your body is stagnant, your brain doesn't produce as many of those hormones that's needed So now we're going to have a decrease in thyroid production, pituitary production, cortisol production, ACTH production, all kinds of really bad things can happen in the body. So immobility, not good. Not good for the body at all. But one of the biggest things that's going to affect is that integumentary system, the skin. Now let's explain how this works and what we can do about it. In order to understand this, I'm going to have you guys play along for just 2 minutes. I want you to take one of your hands and put it underneath your leg. So sit on your hand, please. Now you're going to want to take it out. I need you to sit on your hand for the next 2 minutes. I'll tell you when to take it out. You're going to want to take it out earlier. Please don't. Play along with me because I need to show you something. Okay, so we're going to sit on our hands for 2 minutes. So we've got lots of different pressure points in the body, especially if we're laying down. Remember gravity? We talked about gravity, right? So if I'm laying down, gravity is pulling my body down through all of these points that are contacting the bed. So the backs of the heads, the backs of the shoulders, your elbows, your lower back or coccyx area, back of the thighs, back of the calves, and your heel. These are all places where bone is over muscle pressing down. So that's going to interrupt circulation. So just like your hand, there's bone over muscle pressing down, and that's going to interrupt circulation. And we're going to see what that does in just a second. So when we have bone pressing down onto muscle, fat, and skin, this is going to decrease blood supply to the skin because this is where all of our blood vessels are. So as you have all of that pressure down, what it does is it takes your veins and capillaries like a straw and crimps them. So if we have crimped blood vessels, how much blood are we getting to the area? Nothing. Not much anyway. The same thing happens when we have wrinkles on the sheets because those wrinkles are going to press up from below into the skin. So we have all this pressure pressing down and these wrinkles pressing up. And over time, that is going to affect the skin itself. Since the skin and muscle is caught in between, they start to separate. They start to break down. And this is actually called a pressure sore. So take your hand out and take a really good look at it. I know you guys are all like, thank you. Take a really good look at it. Do you see color changes? Now look really, really close. Can you see the pattern of the chair or your clothing imprinted on your skin? That was 2 minutes. 2 minutes that your hand was there, and you already have imprinting. So what do you think would happen over 24 hours? How deep do you think those lines would get? This is how pressure sores occur. Pressure sores is an area of pressure underneath our patient's body that cuts into the skin with prolonged immobility. So if we left our hand there for several hours, it would actually cause that skin to separate. This is how pressure sores form. The thing about pressure sores are they are preventable. Preventable. So just like you took your hand out, you're now moving it and you're going back, with your life and everything is fine. You're healthy. You've got good nutrition, good blood supply, good cardiovascular. You're breathing fine, so good oxygen. Those lines will go away in just a couple of minutes, and you won't even remember this conversation in 2 hours. But if you didn't move your hand, it would be a whole different story. So when we have an immobile patient, our job is to make sure we're turning that patient every 2 hours around the clock. And that's what's going to help distribute the pressure among different areas of the skin and allow that area to reestablish circulation and reduce the ability for bed sore formation.
I worked at one nursing home, and one lady was like so bad on her hip, and you could see like in the hip, it was open.
Yeah.
You could see the bone and everything. And they had to clean it.
Yeah. And that unfortunately can happen in a very short amount of time. So let's think about this for a second, right? Think about the effects of immobility that we talked about just a few minutes ago, right? Digestion is affected. So that means they're not going to have good nutrients. Circulation is affected. So we're not getting good blood flow to the area. Decreased lung volume. So we're not getting enough oxygen, right? All of those things are going to work against us when we have a wound. Does that make sense? So it's really, really hard to heal a wound when we have an immobile patient. So the whole purpose here is to prevent the wound in the first place. So if that person had been turned like she was supposed to, she probably wouldn't have that wound. And yeah, they can go right down to the bone. Absolutely. Yeah. It's horrible. It's horrible. I have personally performed wound care on way more decubitus ulcers or pressure sores than I care to admit. And it's really sad. And for me, the hardest part about it, nursing homes are great usually at preventing bed sores. Their patients are immobile. They know what to do. They turn the patient every 2 hours. They're pretty much on top of it. But that patient goes to the hospital for 3 days. Hospitals aren't real good at this. Hospitals are focused on whatever brought you to the hospital. They don't care about the rest of your body. Why are you here? Broken leg? We'll treat that. We're going to forget about the rest of you. We're going to treat that, right? So that person who went to the hospital, who was really good turned in the nursing home, they go to the hospital. When they come back to the nursing home, they have a pressure sore. Yeah, that happens a lot too. Yeah. Can we do better than that? What do you think? If we were CNAs at the hospital, would we do better? I would hope so. Yeah. So understand that these stories aren't there to discourage you. They're actually there to motivate you to be a better caregiver to our patients. Okay. Remember, there's bad people in every industry. I've had bad servers at Chili's. I've had bad cashiers at Home Depot. I've had bad healthcare workers. But it just motivates me to be a better one because we need better. Good. Yeah, that's really sad. Really sad. All right. So remember that these changes occurred in only 2 minutes. Imagine if you had left your hand there for hours and hours without moving it. And in general, it only takes, in the right conditions, it only takes about 20 minutes for a bed sore to occur in the right conditions. In general, it takes about 4 to 6 hours. This is why we turn our patients every 2. But if your patient is high risk, particularly high risk, so if they can't take in protein, if they have a respiratory condition, if they have decreased circulation, there's a lot of reasons as a nurse I would consider this patient high risk. I may ask you to turn the patient every hour on the care plan. See how we use the care plan to adapt to our patient's specific needs? You do this automatically. No one has to tell you to do it. You go to bed, you don't wake up in the same position. You toss and you turn all night long. You stretch and you flinch and you move around and you turn and you do all kinds of things all night long. You are probably what you would consider restless. And it's all has to do with this pressure dynamic, because when you are laying in one place for too long, that area that you're laying on is not getting good blood flow. So it rings the brain, says, hey, hello, down here, need blood flow. And the brain says, oh, okay, let me just have her turn over. So you flip over. And after a little while, that part of the body says, hey, brain, not getting good blood flow. So your brain says, hey, leg, kick out a little bit. Right? This is why you move around when you're sleeping. It's all because of this. Now, you've got a healthy body that responds to the brain. Your muscles move, everything works fine. You take care of this on your own. But if somebody can't, if they are immobile and cannot move on their own, now we're responsible for it. Okay? So patients that can't move on their own are going to be repositioned about every 2 hours around the clock. This is what we call standard, every 2 hours around the clock. Now, this can be adjusted. It may be every hour around the clock for those that are at risk. It may be every 4 hours around the clock if the patient has some mobility on their own. They just can't move their trunk. Depends on the needs of the patient. But on average, every 2 hours is how often we're going to turn our patients. Now, this does mean around the clock. I'm waking them up at 2 a.m. I'm waking them up at 4 a.m. I'm waking them up at 6 a.m. to turn them. And some CNAs think they're going to do our patients a favor and let them sleep all night. What do you think is going to happen when we wake them up? What are they going to have? A sore. That's right. Did you do them any favors? Because that sore is probably going to take about 6 months to heal, and they're not going to sleep in that time because of the pain, or it may never heal. Yeah. Yep. So let me go back here. So when we're turning our patients, it's going to be from the back, their back. So they start out on their back, right side for 2 hours, back to their back for 2 hours, left side for 2 hours, back to their back for 2 hours, right back, left back, right back, left back, around the clock. You can actually make a turning clock like this and put it on the wall. Most facilities will already have one. So as a nurse, if I walk in and it is 10 o'clock in the morning, I can look at this, 10 o'clock in the morning. It's a little after 10 o'clock in the morning. So where should my patient be? On his back. If I notice that the patient is not on his back, I don't have a CNA that's turning that patient. So most facilities will have a turning clock similar to this. If not, you can make one. This is in the purview of a CNA. You can make a turning clock like this, put it on the wall so everybody is following it. Okay. It's also good for you because when you've got multiple patients, you got 10, 12 patients you're taking care of, you may not remember, oh my gosh, did I just put him on his back or his side? I can't remember. So this can help you. Okay. Good. All right. Notice that didn't say stomach. Let's go back there for a second. Notice nowhere on there does it say put them on their stomach. Do not put a patient that's immobile on their stomach unless care plan specifically tells you to. Because if that patient has a neurological problem, they may not be able to lift themselves off of their chest cavity to allow their lungs to inflate. You can suffocate a patient by putting them on their stomach. So we don't put them on their stomach unless our care plan specifically tells us to. So we talked about this on Monday. Patients must be in the middle of the bed, the safe zone. Even when they're on their side, they're going to be in the middle of the bed. Side rails are not there to keep them in the middle of the bed. We're going to use body mechanics to do that instead. Don't just roll them. If you roll them, they're too close to the edge and they will fall. So in order to do this, we're going to ask them to scoot toward us, and then we roll them away from us so that they're in the middle of the bed after the turn. Good? Good. Now, if your patient can't scoot towards you, then you can use a draw sheet. A draw sheet, wrong way. Let's go this way. Okay. So this bed actually has a draw sheet on it. Do you see the sheet here that's underneath the patient? This is just a top sheet folded in half lengthwise. Now I can use this sheet as a sling to move my patient in the bed. So if I wanted to move my patient toward me in order to roll them up on their side, I would loosen both sides of this sheet. Keep our patient covered. I'm going to loosen this sheet as well, this side. I would come up back over here. So if I want to Scoot this patient toward me to roll him up on his side. I'm going to take this draw sheet, roll it up so I can grab it, wide base of support, and scoot the patient toward me. Okay, we use it like a sling. You can also move the patient in segments. So I can grab their shoulders and head, and then, it's always backwards. Okay, so I can slide their shoulder and head, and then their torso, and then their hips, and then their legs if I need to. Care plan will tell you which method you need to use with that patient. So this is how a draw sheet works. I just showed you on the bed, but this is how a draw sheet works. It's a long sheet, a top sheet, folded in half longwise underneath the patient. Folded edge is always under the shoulders, not the two parts that go together. The folded part goes under their shoulders. The two pieces that come together go under their legs. So this is going to go from shoulder to mid-thigh and create a sling. So in order to turn a patient onto their side, we need to position them in a very specific way. The furthest arm goes up and the closest arm crosses their chest. They're going to look like this if I'm turning them on their left. If I was turning them on their right, furthest arm up, closest arm over. Remember that you're always turning a patient away from you. Okay? So if I'm turning them on their left, furthest arm up, I'll stand here, furthest arm up, closest arm over. With the legs, the closest knee is going to get bent with a foot flat on the bed, and the furthest knee gets angled out. So when I get a patient in this position, it takes no effort at all for me to just push them on their side. No effort. It doesn't hurt them or me. And I can turn somebody 3 times my body weight by positioning them in this position first, with no stress on them or me. Okay. All right. So good? So sideline position, furthest arm up, closest arm crosses the chest, closest knee bent with foot on the bed, and furthest knee is angled out. We'll roll the patient in the middle of the bed. We want that upper leg to be just in front of the lower leg, so they're not just like right on top of each other, just a little offset. And we're going to put a pillow in between those legs, specifically between the knees and the ankles. We don't want those bony areas rubbing together, which could cause a sore. We're going to put a pillow behind the back to keep them on their side, because remember, gravity is always trying to pull them back. So we'll put a pillow behind their back, and we're going to put a pillow under that top arm. Because when you have a patient laying on their side, that arm kind of falls down. It puts a lot of pressure along the upper back and into the neck, can cause headaches and muscle spasms. So putting a pillow under that top arm gets it in a neutral position. Remember, they're stuck here for 2 hours. 2 hours before you come move them again. So we want to make sure they're comfortable. So at the end of this skill, when you get the patient positioned, you need to take a step back and look at the patient. Are they too close to the edge of the bed? Do they look comfortable? We want to ask them, are you comfortable? Because remember, they can't, if they're uncomfortable, they can't fix it. They're not able to move. So take a step back and look at your patient before you end this skill, okay? Call light is going to go in the lower hand so that cord does not go over their neck. That's a safety issue. So let's look at the care plan one more time. Position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. So I'm going to show you the video for this one because it's got really good close-ups. Pay attention to the pillow behind the back. That pillow behind the back is really tricky. I make it look a lot easier than it actually is, okay? And then after we do that, we'll take a quick break. don't know why it's not like this. Sorry. Why isn't it playing through the TV? All right.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to turn you onto your left side. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies, and I'll be right back.
Okay. Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to turn you onto your left side. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies, and I'll be right back.
Okay.
I'll start gathering your supplies. We'll start with a barrier, which I'll place on the table to provide a clean area to place my supplies. And I'll get 3 pillows from clean supply cabinet, being careful not to allow them to touch my uniform. Mr. Jones, I'm going to place this blanket over you, and this will help keep you warm and protect your privacy while we do this skill. Once I have the blanket in place, then I'll pull the sheet down underneath the blanket, making sure the patient remains covered at all times. Okay, Mr. Jones, if I could have you scoot toward me, please. I'm going to place your furthest arm above your head and cross your closest arm over your chest. I'm going to bend the closest knee and put the foot flat on the bed. And I'm going to angle the furthest knee out a little bit. Okay, now I'm going to turn you onto your side. 1, 2, 3. Okay, I'm going to take the first pillow and put it in an angle up against the back, and I'm going to tuck this top edge underneath the patient by pushing down on the pillow and under his back. This edge will roll up, and then it too will be pushed down and under, forming a roll along the back. Okay, now I'm going to position a pillow between the 2 legs by lifting the top leg and laying the pillow lengthwise between the 2 legs, specifically between the knees and the ankles, to prevent those bony areas from rubbing together. This pillow is going to be placed underneath the upper arm. This will help keep the arm in a neutral position as the patient remains on their side. And then I'm going to adjust the pillow underneath the head to make sure that it's not under the shoulder and it remains only under the head and the neck. And then move the arm to a more comfortable position. Is that comfortable, Mr. Jones?
Yes.
Okay, I'm going to place the collar directly in your hand. Are you comfortable?
Yes.
Can I get you anything else while I'm here?
No.
Okay, let me pull your sheet up. And remove the privacy blanket. Being careful not to dislodge all of those pillows as I do so. I'll roll the privacy blanket up and place it in dirty linen. The barrier will be thrown away. Okay, Mr. Jones, I'm going to open your privacy curtain now. Is there anything else I can get for you while I'm here?
No, thank you.
Okay, I'll see you soon. Let me go wash my hands. After washing my hands, I'll review all the steps of my skill, make any corrections, and tell the evaluator my skill is done. Okay, any questions on that? Any questions? So a question that came up during the video is, can you use a blanket, a rolled blanket behind the patient instead of the pillow? And yes, you can. But you need to learn how to use the pillows, because pillows in a roll, or folded like that in a roll, are actually more secure than the blankets are. The blankets can roll off, and it gives a little bit more dimension. Any others?
That back one looks like it lifts up the hip off the bed.
It
So we don't
does.
get sore.
Yeah, it does. It provides a little bit different kind of support than a blanket would. But that's the hard one to learn how to do. You're going to have to practice that one. It's not as easy as I make it look. I got a lot of experience. All right, let's go ahead and take your break. We'll give 15 minutes. And then when you come back, we're going to get into 2 additional skills. And there we go. And then do the state test application. Thanks. Okay. All right, we've got a question here. How do I know if my insulin is low if I've never been diagnosed with diabetes? Unfortunately, that's not something that we are able to talk about in this class. I don't give personal health recommendations. You would need to follow up with your physician because everybody's individual. There's a lot of things that go into that. But Anna asks, do I have to check or mention if the bed wheels are locked during the opening and closing? And that's a good question. For the test, the wheels will already be locked. You can certainly bump the bed and just make sure. You can say something out loud. But it's not, in Florida, it is not a testing checkpoint. Okay, so you can do that if you want to, but in Florida, it's not a testing checkpoint. There are, I think, 2 states that it is, though, and I can't remember which one's off the top of my head. But in Florida, it's not. All right. Okay, so let's move on to foot care. This is on page 118 of your book. Good news is there's nothing to learn. Do you guys remember hand and nail care? Foot care is hand and nail care, just a little lower. And we don't do anything with the nails. So with hand care, we clean the nails and file the rough edges. We don't do that with foot care. We just soak the foot, wash the foot, rinse the foot, dry the foot, and lotion the foot. That's it. And care plan is only going to tell us to do 1 foot. That's it. In a clinical setting, podiatrists, which is a foot doctor, will come in and take care of the toenails. But the way this works is you do foot care. You notice the toenails are long. You report it to the nurse. The nurse puts the patient on the podiatry list. And when the podiatrist comes in, they see the people on the list. So this really does start with us. But it's actually not why we're doing foot care. And I'm going to get into cleaning the foot is not why we're doing foot care. And I'm going to get into that here. So no new principles learned. We know all the principles involved in this. So that's nice. If you look at the care plan, top page 119, it tells us to provide foot care to 1 foot using soap and water. The resident is sitting in a chair and their sock and shoe should be replaced at the end of the skill. So let me explain to you why that last sentence is in there. This is a live patient skill. So if we go back here and look at our test specific information, live student sitting in a chair for this skill. Now they give you 13 minutes to wash 1 foot, which is way more time than you actually need. But it's a live patient skill. It means you might be a patient for this. You're probably not taking an extra pair of socks to the testing center with you, are you? Don't have extra socks in your pockets anywhere? No? Yeah, either does anybody else. So for this skill, if you are the patient, the care plan says to put your sock and shoe back on. In a clinical setting, if we're washing the feet, we're going to put clean socks on the clean foot. But we don't happen to have any here. Make sense? Okay. So that's why that sentence is there. Their sock and shoes should be replaced at the end of the skill. And that's because we have a principle here. When the patient's feet hit the floor, we got to talk about their shoes. We should not have feet without shoes on the floor. That's a safety issue. So if you just wash, rinse, and dry the foot, put some lotion on it, and then just leave it, now we've got a bare foot on the floor, which is not according to our standards. Good? Make sense? All right. So foot care, a whole lot like hand and nail care. With hand and nail care, we supported the wrist and arm at all times. With foot care, we'll support the foot and leg at all times. Same thing. We're going to soak the hand in water. We're going to soak the foot in water. We washed, rinsed, and dried. We're going to wash, rinse, and dry. I mean, a lot of correlations there. Now, this is where it gets a little bit tricky, okay? So here, we used a beveled edge to clean under the nails. We're not doing that with toes. Here, we wipe that orange stick off between. We're not doing that. Here, we use an emery board to file the nails in one direction. We're not doing that. What we are going to do is inspect all surfaces. You want to look. That's the super important part of this skill is to look at the foot. And remember I said that as we age, we get less bendy, right? So as we age, we're more prone to injury. It may be less likely that we'll feel the injury because our nervous system isn't working the way it used to. So that means we may have an injury that we don't know about, and we can't look at the bottom of our feet because we're not bendy. So we've got injuries that nobody knows about, which means that they may not be healing. The whole purpose of this is to look at the foot. They figure if you soak the foot, wash the foot, rinse the foot, dry the foot, and lotion the foot, somewhere in there, you might actually look at the foot. Now, when we put lotion on, we don't want lotion between the toes because that just creates a warm, dark, moist environment that can contribute to athlete's foot and other infections. No bare feet on the floor. We talked about that. We'll replace the sock and remove wrinkles. Remember, wrinkles are our enemy. And we'll apply and secure the shoe over the sock. But in order to understand this skill, we have to talk a little bit about diabetes. Now, what I'm going to tell you is a 5th grade version of diabetes. Remember, I'm dumbing this way, 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 way down, okay? There are healthcare professionals that spend years studying diabetes to become experts. That's not what this is. But it is important that you have a general understanding of this because you will have a significant amount of your patients with diabetes. In fact, the estimates now are 1 out of every 2 adults over the age of, I think it's 65, will develop diabetes. So half of our patients. So this is pretty important. So how does that work? How come all of a sudden half of our people are developing diabetes? We're going to get to that in a minute because it did not start in their 70s. And I'll explain why. So, the way diabetes works, turn this a little bit. The way diabetes works is every cell in your body needs fuel to run, just like your car does. Now, for your car, you go to the gas station, you get gas in it, and it runs for you. Well, in the body, the fuel the cells need is sugar or glucose. And we get that sugar or glucose through taking in carbs. So you eat carbs, the carbs break down into sugar, the sugar goes into your bloodstream and eventually into your cells. It feeds the cells, they're happy, and everything works well. So that's this cycle. You eat carbs, they break down into sugar, the sugar enters the cells, and the cells are happy. Now, the cells can't take in glucose by themselves, though. Every cell is actually locked. In order for that glucose to get into the cell, we have to have a key. That key is a hormone called insulin. Insulin is created by your pancreas. So you eat carbs. Those carbs break down into sugar. Your brain tells your pancreas, hey, we need some keys. Pancreas puts out some insulin. Insulin opens the door to the cell, and the sugar goes in. You guys understand that process? Okay. So insulin is triggered when you eat carbs. It doesn't just kind of hang around all the time. It's an on-demand system. Good? Okay. So that's what this is going to show you. We have a starving cell. Cell tells the brain, hey, I'm starving. The brain says, oh, we need some glucose. And will trigger a craving. Make you hungry. So you go eat, usually carbs. In America, we eat a lot of carbs. Most of our diet is carbs because they taste good. So that those carbs break down into sugar and go into the bloodstream. Your pancreas produces insulin. Insulin opens the door, and the sugar is then able to enter the cell, and everybody's happy. That is a normally functioning glucose system. Good? So what happens when we have diabetes? Well, the system is still there. We still eat carbs. They still break down into sugar. The sugar still goes into the bloodstream, but it can't get into the cells because there's no key. So now those cells can see all the glucose. Hey, I'm starving. You're here. But the glucose can't get in. So all of that glucose just piles up in the bloodstream, and we call it high blood sugar. Make sense? It's high because that sugar should be in the cells, but it can't get there. Okay, good. And it can't get there because the insulin isn't being produced by the pancreas. Or, so either your pancreas just quit working, or the pancreas is making the wrong kind of key. It's making car keys. We need house keys. It's a key, but it's not effective. It's not unlocking what we need it to unlock. That's called insulin resistance or pre-diabetes. Good? Got it? So why do we care? Well, we got this thing called gravity on planet Earth. We've learned a lot about gravity, haven't we? Well, sugar is a crystal. So have you ever made like a cupcake or a cake and left it down on the counter for a couple days? The frosting, right, which is sugar, that frosting gets kind of gritty, a little crystally, right? A little hard. That is sugar. That's what it looks like. That is exactly what the sugar looks like in your bloodstream. So if it's not getting into the cells, it's just circulating in your body. And it looks kind of like this. See all those sharp, jagged edges? Yeah, so when all of this sugar is in your bloodstream, right? It's just in your bloodstream circulating. It's going to settle on the inside of your arteries. And because it's a crystal, it's going to make the arteries stiff. So they can't expand when you need more blood. They can't contract to stop bleeding. They're kind of stuck in this one position because it's stiff from all the sugar. But all of these sharp, jagged edges that are sticking out are going to catch everything that's floating by, like cholesterol. Now, cholesterol is like pizza cheese in the inside of your arteries, and it gets all tangled up in these crystals. So now we've got a big, gloppy, gluey mess inside our arteries. It's also going to shred cells that are floating by. So now we have fewer red blood cells that can carry oxygen, fewer immune cells that can help prevent infection, fewer platelets to stop bleeding. So is this a recipe for anything good? All right, so because sugar is a crystal, it's heavy, molecularly speaking. And gravity is going to pull heavy things down. So what is the lowest point of my upper body? Hands. What is the lowest point of my lower body? Feet. So where do you think we're going to have the most effects from all of this excess sugar running around in the body? Hands and feet. Hand care, foot care. Start to see why we're doing these 2 skills. Got it? Make sense? All right, so let me explain to you why this is important. This is what the inside of our artery looks like when we're brand new. This is a nice artery. It's wide open, no thickening anywhere. This is a brand new artery, works great. It's not going to stay that way though, because in America, we sabotage our bodies. Now, let me explain to you, before we go further, let me explain to you why people in their 60s and 70s are developing diabetes. It actually didn't start when they're in their 60s and 70s. It started when they're 2. So we got a 2 or 3-year-old that gets up at 5 o'clock in the morning. Mom's like, oh, it is way too early. Parks the kid in front of the TV and hands him a Pop-Tart to buy him a little bit of time and naps on the couch. So the kid eats the Pop-Tart. The Pop-Tart is carbs that break down into sugar, so their pancreas has to produce insulin. So mom gets up around 6:37 and gives the kid a bowl of cereal, a proper breakfast. So kids don't eat all bran, do they? What do they eat? Fruity Pebbles, Captain Crunch, right? All the good cereal, but those are all carbs that break down into sugar, and that makes the pancreas produce insulin. So mid-morning snack, mom's a good mom. She gives the kid fruit, but fruit is fructose, which is sugar, which makes the pancreas produce insulin. So now we're at lunch. The national toddler approved lunch menu is chicken nuggets and mac and cheese, which is a little bit of protein, but a whole lot of carbs that break down into sugar and make the pancreas produce insulin. Afternoon snack, we're going to get a little Debbie something, which is all sugar in the bloodstream, makes the pancreas produce insulin. Dinner time, buttered spaghetti, which are carbs, breaks down into sugar, makes the pancreas produce insulin. And then at night before bed, we have a dessert, which is always something sweet, which makes the pancreas produce insulin. And we don't change our diet a whole lot as we age. If you look at the amount of carbs that you eat on a daily basis, those carbs make your pancreas produce insulin. So this isn't a problem that they just developed at 60 or 70 years old. They have worn their pancreas out. The pancreas is like, that's it, I'm done. I'm not giving anymore. I'm done. Done. So they develop diabetes. Now, they're all confused. Well, I never had diabetes before. No, because your pancreas was still working. It's not working now because it's been overused. Does that make sense? Yes. So you young people, work in more protein into your diet, a little less carbohydrates, and you can help avoid this in the future. Good? So let me explain to you what happens in the body when we take in more glucose than we can actually use. Okay? So we take in carbs, they break down into sugar, our pancreas produces insulin and allows that glucose to go into the cells. But usually there's a little bit left over. Like your cells don't use all of the glucose. So there's some left over. Now the problem with glucose is you can't pee it out. Like what's there is there. It doesn't go out of your body. It's not like vitamin C. You take too much vitamin C, you'll pee out what you don't need. Glucose doesn't work that way. It'd be a whole lot easier if it did. What happens is your body stores the excess glucose. It puts it into packing boxes called glycogen, And it puts those glycogen in storage units we call fat cells. So the more fat cells you have, the more glucose you're storing. Now that's a good thing because later in your life, you may not have a good source of glucose. So your body can go to the storage unit, unpack, and utilize what it has in storage. But glucose, kind of like home furnishings, has an expiration date. You know, we're not using shag carpet and avocado green anymore. Although back in the 70s, it was all the rage, right? So if you go to a storage unit, there's probably some shag carpeting and avocado green in there. You're not interested in that because it's old. It's outdated, right? I know it's coming back in style now. I got to use something else. It's coming back in style now, but it's old and outdated. Well, that's what happens with a lot of our glycogen. It's been stored so long that it's really hard for the body to use it. It's just not good quality anymore. It's degraded over time. That's why it's hard to lose weight, because it's hard to utilize that glucose when it's old. Does that make sense? Good? All right. So eventually you run out of fat cells, and that's when the glucose just kind of stacks up in the bloodstream, and we end up with these kind of problems. Good? So that's what it looks like in your bloodstream. So this was our brand new artery. This is one where we're starting to get just a little bit of buildup. Do you see that little bit of buildup there? See how that one is a little bit narrower? This isn't causing a huge amount of problems yet. You probably haven't even noticed. Blood pressure might be up a little bit because the inside diameter is smaller, right? So blood pressure might be up just a little bit, but nothing significant. But if we ignore this, then we start to really build up. And this we're going to get a little bit of symptoms out of, because about a quarter of our space for blood is gone. It's all gunked up. We're also shredding cells at this point, because inside here are these sharp, jagged pieces. Now, if we ignore this and we get into diabetes, this is what our bloodstream looks like. Now, anytime blood slows down or stops, it clots. That's what you see there. That is a blood clot. So if we have a patient with diabetes, what do you think they're at risk for? Blood clots, because that blood has slowed down or stopped. Do you see how that could be a problem? Okay, so you guys understand diabetes? Okay. Remember that these effects are going to be more pronounced in the hands and the feet just because of gravity. Now, we also have some nerve effects as well. It doesn't just, wait, it gets worse. It doesn't just affect the inside of your arteries. It also affects your nerves as well. It'll coat the nerves. So years and years ago, I was an agency nurse. They're substitute nurses. They don't work for the facility. They are nurses that are sent in when the facility nurse is not available. So like a substitute teacher at school. Okay, substitute nurse. So I go into this facility. I'm on the rehab side seeing my patients. And the patient that I went in to see, I get his medication. I got report when I got in, get his medication. I go into the room, and he was laying in bed, and he had a little tiny light right above his bed, one of those little fluorescent lights, but the rest of the lights in the room were off. So I flipped on the light as I walked in because I got to do my assessment, and he starts yelling right away, "Turn the light off, turn the light off." Okay. So I turned the light off, walked up to the bed, and I said, "Hi, Henry. My name is Patty. I'm your nurse today. And is there a reason we don't want the light on? Do you have a headache or something? What's going on?" Because it's part of my assessment. It's an observation. You start to see how important these observations are, right? He doesn't want the light on. That's something you should be reporting, no matter how minor it seems to you, because there's a story there. There's a reason. So I asked him. He says, "Yeah, I've got diabetic retinopathy, and the bright light really hurts my eyes." Okay, cool, no problem. So I'm standing there talking to him, doing my assessment, got his pills in my hand, and as I'm standing there, I'm catching an odor. Now, if you've ever smelled a wound, they're very distinctive in odor. And I'm realizing that this guy's probably got a wound brewing somewhere because I can smell it. So I pick out my report sheet out of my pocket and I'm looking, and there's nothing on the report sheet for this guy about a wound treatments, nothing. Uh-oh, that's not good. So I asked him, hey, Henry, I think you might have a wound brewing somewhere. Can I take a quick peek? He says, do what you got to do. Now, this guy was in his mid-50s, which sounds old to you guys, but it's not. He was very gruff, ex-military, didn't have any fine edges anywhere. And he basically said, do what you got to do. So I turned him over and I looked at all the usual suspects, the ones that we were looking at earlier, the back of the head, the shoulders, the lower back or coccyx area, the back of the legs. And I get down to his feet and I'm not seeing any wounds so far, but he's got those slipper socks on. You know, the kind that have the white dots on the bottom of them? Mm-hmm. Okay. So I said, hey, Henry, I need to take your socks off and take a look at your feet. He immediately barks, no. Okay. There's my red flag. So he's telling me no. What do you think he told the CNAs? No. And the CNAs didn't report that. We have no idea how long this guy had gone with nobody looking at his feet. No idea. But he's not going to do it on my watch. So I sweet talked him because you can always get further with people by being nice than being mean. So I turned up the charm, and I'm hard to resist when I get charming. So I turned up the charm, and I got him to agree to let me take a look at his feet. I took the left sock off, and the foot was flaky, definitely needed some care, but not in bad shape. Tried to get the right sock off, and it was stuck to the bottom of his foot. Found it! Here's my problem, but I can't see what the problem is because the sock is stuck. So I get a big basin of warm salt water, we call it normal saline, put his whole foot in it, sock and all, and leave him, go take care of another patient and come back. Wash my hands, get my gloves on, and I'm taking the sock off, and I had to give it a little bit of pressure because it was really stuck, but I got to see what I'm working with here. So as I kind of pulled a little bit on the sock to try just to get it dislodged, something fell off of his foot and rolled. Now I'm counting toes. They're all there. That's good. So what came off of this guy's foot? And the floor was just like this. Okay, the industrial floor, speckled. Baseboards were just like this. And up next to the baseboard was one of these. This is a flat metal white painted thumbtack. This had been in the bottom of his foot. And we don't know how long. And this was a catastrophic cascade of failures. So let me explain what I mean. First of all, he was walking around without shoes. Second of all, the CNAs weren't inspecting his feet. He was refusing. The third failure is the CNAs weren't reporting to the nurse that he was refusing. The fourth failure is he wanted the lights off in his room so nobody could see this. Okay, so a cascade of failures. It wasn't a single point of failure. It was a lot of things together. But one of the questions that everybody asks is, wait. How did he have a thumbtack in the bottom of his foot and not feel it, not know it? Certainly, if I step on a thumbtack, I'm going to know it's there, 100%. You guys see this? This is what happens. Your sugar, when you have excess sugar, is going to coat those nerves. So the foot knew the thumbtack was there. The foot knew. But it tried to get that signal from the foot to the brain. It's not wireless. It's wired. It's nerves. So that signal wasn't able to travel from the foot all the way to the brain. So the foot knew there was something there, but the brain did not. Now, he wasn't bendy. He had no idea there was something in his foot. His foot wasn't telling him there was something there. So I managed to get the sock off. And on the bottom of his foot, an area about this big around, hard, black, dead tissue. Now, we're good in healthcare. We can solve a lot of problems. We can treat a lot of issues. But dead is dead. We don't bring dead tissue back to life. There is no way of doing that. Frankenstein tried it, didn't work, right? So we need to be aware that what we do matters. So I called the doctor, called the wound care specialist, called the family, charted everything, took my pictures, did everything I needed to do, and left. Not my patient, not my facility. But boy, did he stay on my mind, because he was way too young to have something like this happen. And it was sometime later. I don't know how many months, but it was a while later. 9, 10, 11, maybe a year. I don't know. It was a long time later. I get assigned back to that facility, but this time I'm on the long-term care side. And as I'm going through my report, I recognize a name. So I walked into his room and I said, "Hey, Henry, it's Patty. I'm the nurse that found the wound on your foot long time ago. How are you doing?" And he pulled the covers back, and he had to have a below-the-knee amputation. He lost his leg over this. Remember, diabetes. It means that we aren't getting good blood flow to wounds. So if we find a wound, we may not be able to heal it, which is what happened with this guy. He went through months of wound care treatment. It wasn't effective. They had to amputate. Now he's on long-term care side. That means he lives there now. In his 50s. How horrible is that? I am in my 50s. I would not want to be living at a nursing home. Do you guys see how tragic that was? What made it even more tragic for me is it was 100% preventable. If he had shoes on, where would that thumbtack be?
Not there. Not there.
Not there. We don't amputate shoes. Are you starting to see that shoes are important here? If the patient's feet hit the floor, we've got to talk about their shoes. Good?
Yes.
It also breaks my heart that the CNAs weren't doing their jobs. Because if you had gone in to do foot care and he said no, and you came to me and said, "Hey, he won't let me touch his feet," that would have been a red flag for me to go in and take a look. Right? CNAs do normal. So if he says no, that's okay. It then becomes my job. But I have to know. So if the CNAs don't report, if the CNAs don't tell me, "Hey, he wants his light off all the time." Lights off mean things are going to be missed. Right? Does that make sense? You starting to see how important your job is? They really should pay you more. Really? They should. There's a reason they don't. We might have time to get into it later, but there's a reason they don't. But we've got to take what we do very seriously. Does that make sense? Good. So when we're working with diabetic patients, we really need to be looking at their hands and their feet, because that's where the most of the issues are going to show up. Okay. All right. So shoe rules. We're just going to talk about the first two. We're going to get to the rest of them later on in another. This is our last principle, by the way. This is it. This is the last one. We know the rest of them. I told you on the first day that you would know all of these by the end of the second week. And here we are at the end of the second week. Wasn't hard, was it? No. All right. So if the patient's feet hit the floor, we talk about their shoes. And this just reminds us how important shoes are, that our patients should not have bare feet on the floor and they should not be walking around in just socks, even slipper socks, because slipper socks don't protect the feet against injury. And in healthcare, we have all kinds of sharp things. We have thumbtacks, but we also have needles and lancets and glass vials and IVs and all kinds of stuff, right? If you wouldn't let a child walk barefoot in that room, don't ask an adult to do it. Does that make sense? I can't tell you how many CNAs I've asked, do you have children? Do you have children? No. Who has children? Do you have children? Would you let your child walk barefoot in a hospital room? So why do we ask our patients to? Right? So we give them these little slipper socks and we think that's enough. So let's talk about this scenario for a second. Let's say that your instructor, had a gallbladder surgery this morning, and it's robotic, just a little incision. I was supposed to go home at the end of the day, but unfortunately, my blood pressure was a little bit high, so they had to keep me overnight for observation, and they gave me that bed over there. So I was there last night. I'm getting ready to be discharged today, but I haven't quite made it there. This is my roommate. I didn't get to pick her. She had a hip replacement. She's in her 70s. And she developed an infection in the incision. So they put her on IV antibiotics. Now, the IV antibiotics are super, super strong. And one of the side effects is it gave her diarrhea. Well, she can't really get to the bathroom all that well because she just had a hip replacement. So unfortunately, there was some leakage that occurred on the way to the bathroom. And I got out of bed and walked to the bathroom in my little slipper socks and did what I needed to do and walked back to bed and got into bed with those same slipper socks on. What crawled into bed with me? All those pathogens and diarrhea particles. Yeah. Do you know what I have? I have incisions. Do you know what incisions are? Warm, dark, moist places. So I brought pathogens to bed with me and gave them great places to cuddle up. So did I increase my risk of a surgical site infection? Because I didn't wear shoes. Are slipper socks enough? No, they don't protect against injury, and they definitely don't protect against pathogens. So what if your patient doesn't have shoes? Well, that's an observation. What do we do with observations? Report them to the nurse. The nurse has resources. We can call the facility. Hey, can you bring Georgia's shoes over? I need Georgia's shoes. We can call the family. Hey, does your mom have shoes? Could you bring some in next time you come visit? We can call social services. If the patient is homeless and has no shoe, we have resources. No problem. But I can't act on it if I don't know it's a problem. So all observations, no matter how small, get reported to the nurse. Good? You guys starting to see just how important that skill rules banner is over there? That's going to make up about 90% of your test, right? Follow the care plan and report everything to the nurse. If you remember that, the test is easy. Okay, good. So we're going to talk about their shoes. For the test, we're going to put shoes on put their shoe on at the end of the skill, and we're going to say something while we're cleaning the foot that we're looking at it. Okay. So this skill is all about observation and making sure that the patient is safe at the end by wearing shoes. Remember, slipper socks are not enough to protect from injury or pathogens. So when we're doing foot care, we're going to soak the foot, take it out and wash it, put it back in to rinse it, take it out to dry it. During that time, we're going to look. We're going to look. And we're going to say something that we're looking. I'm looking at your foot. I don't see any red areas on your feet. Your skin looks good on your foot. I don't care what you say. I don't care how you say it, but you have to address it in some way so the evaluators know that you know why you're there. That this skill really has nothing to do with cleaning. It has everything to do with looking. We're cleaning to give us an excuse to look. Good? Questions? All right. So page 119 has our care plan at the top, step-by-step instructions. This gray box has some questions. If you can answer these, you're good. You know what to do for the skill. And then you see all of the supplies. This has a lot of supplies, guys. You have to memorize your supplies. Nobody's going to tell you. For this skill, you need a basin, soap, lotion, a chucks on the floor. You need shoe and sock. You need a set of gloves. Because we're looking at the foot, we don't know if there's a wound. We don't know. Because we don't know, we're going to wear gloves. Okay? So you do need gloves for this skill. But nobody's going to tell you all of the supplies that you need. You have to know them. For small body parts, if you're going to wash a small body part like a hand or a foot, you need 2 washcloths, 1 to wash, 1 to rinse. So hand care, foot care, 2 washcloths. Everything else, 4. Okay? Try to remember that. Hand care, foot care, 2 washcloths. Everything else, 4. Good? Let me show you this skill. I'm not getting on the floor, so. All right. Oh, cool. Okay. So let's congratulate Marsha. I passed my clinical yesterday. Thank you so much for your CNA videos. Congratulations. Julia says, hey, Miss Patty, I'm Julia. Sorry I couldn't attend class today, but I'm watching you live. Awesome. Thank you for watching. And yes, Julia, I did get your email. I will send out Monday's email for you. All right, so let's watch foot care.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
Wonderful. I need to do foot care. Is that okay?
Yes.
Let me go close your curtain, wash my hands, and then I'll gather your supplies.
Okay.
Nice done. Okay, I'm going to get a barrier, and we'll place this on the floor right in front of you, and you can place your foot on the barrier. I'm going to get a basin, soap, and lotion. We'll place that on the barrier. I'm going to get 2 washcloths and a towel and a set of gloves. I'm going to get some water for washing.
Remember, that just follows our washing rule.
Okay, Mr. Jones, would you like to check the water temperature and make sure it's okay?
Yes.
Is it
Great.
good?
Yes, great.
Very good. I'm going to set this here. And I'm going to kneel on the barrier and apply my gloves. I'm going to roll up your pants leg and lift your foot so I can remove your sock. We'll place your foot in the basin to soak. I'll take the first washcloth and wring it out.
making sure that your foot is wet. I'm going to place your foot over here on the towel and apply soap to the washcloth. You want to wash all surfaces of the foot. I'm going to lift your foot up so I can wash the bottom, and I'll observe for any red areas, wounds, sores, or any other abnormalities. We'll put your foot back in the basin to rinse. Okay, I'm going to place your foot on the towel to dry. And I'll ensure all surfaces have been dried thoroughly. I'll take one of the narrow edges and go between your toes to blot. And I'll dry the bottom of your foot. Now I'm going to apply some lotion. We'll warm the lotion in our hands. And apply lotion to all surfaces except between the toes. So I'm going to lift your foot, and we'll apply lotion to the bottom as well as the top. And now I'm going to wipe off the excess lotion so that you don't slip. Okay, go ahead and place your foot back on the barrier. And now I can reapply your sock. Okay. And we'll put your shoe back on. Can you slide your foot in there for me, please? Okay, Mr. Jones, I need to put all of my supplies away now. I'm going to gather my dirty linen and place it in the dirty linen hamper. I'm going to take the basin to the sink and clean according to the basin cleaning procedure. On the way back, I'll collect the soap and the lotion and put the basin back in the drawer. Now I'll collect the barrier and throw it away. Now I can remove my gloves. Okay, Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is here. If you should need anything at all, please let me know. Can I get you a magazine while you're waiting?
No, thank you.
I'm going to open my curtain and wash my hands. After washing my hands, I'll review the steps in my skill, make any corrections, and tell the evaluator my skill is done.
All right. Any questions on that? For this skill, it's really done for real on a real person, and you really have to get on the floor. For me, this is the hardest skill because I don't get up very well anymore. So this is the hardest skill. But it's still not very hard. You're just washing something. Good? Questions? All right, moving on. Let's go to mouth care. It's not much to teach you on this one. You guys all know how to brush teeth. No, they won't have shoes on in bed. So yeah, a lot of them will have a hard sole slip-on type of shoe. So Crocs, slipper with a harder sole. Yeah, it depends on where they are, the setting that they're in. If they're in a nursing home and they get up and walk on their own, they'll have shoes, actual shoes. So we don't like slip-on shoes when somebody is walking. We want something that's secure on the feet so that it reduces tripping hazards. Okay. So it depends on the needs of that particular patient. All right, so not much to learn here on mouth care. If you look down the edge here, you can see all the principles involved. They're all spelled out for you here. There's nothing to learn. We're going to follow the care plan, do our opening. We're going to be working with body fluids, so gloves are required. We need a barrier to put all of our stuff on. We need some linens, specifically a towel. We're going to clean our basin after they spit in it, so we just rinse it, dry it, and store it. And we do our closing. Nothing here to learn. You can see I have a video for that. This is going to be done on that means you might be having your teeth brushed by a stranger on test day. I know, nobody likes it. Nobody likes it. So that brings me to my next subject. If your patient can brush their own teeth, you won't be doing this. Just like you feel it's a bit icky during the test to have some stranger brushing your teeth when you're capable of doing it yourself, your patients feel the same way. So in a clinical setting, if your patient can brush her own teeth, they're going to. We're not involved. Right? Make sense? Make sense? All right. So no new principles to learn. Top of page 93 has our care plan. It says a patient with natural teeth is lying in bed and needs mouth care. Is that a safe position? No, so we need to get the head of the bed up for safety. It says the resident is not able to provide their own mouth care. Supplies are located at the bottom. And again, there's lots of supplies. You need to make flashcards or learn. Safety first. Your patient is lying in bed. That means we've got to get the head of the bed up. Now, we want to prevent aspiration. That is a term you do need to know. Aspiration means to breathe food or fluid into the lungs where it does not belong. So we want to prevent that. So we want to put the head of the bed up. Now, I am going to show you the video for this because it has good close-ups that you guys need to see. However, there is a change between the video that I'm going to show you and the way I need you to do the skill. So let me go over that change. I'm getting ready to redo the videos. So this will change. The new one will be better, but we have to put the head of the bed up. If you remember during our opening, we can't touch the resident until our hands are clean. Is that bed controller clean? No, because everybody touches it. So if we've washed our hands and then we're going to do mouth care, do we really want to touch that bed controller with clean hands? No, but we have to have clean hands to touch the patient. So this is one of those kind of gray area things. So the video I'm going to show you, I put the head of the bed up before I go wash my hands. But the way that they want us to do it is wash our hands and then put the head of the bed up. But we're going to use a paper towel between our hand and the controller. Does that make sense? Everybody got that? So the video, I put the head of the bed up first before I wash my hands. Don't do that. Wash your hands, then put the head of the bed up using a paper towel. Okay? You'll see that in the book, okay, on step 7. I've done my opening, washed my hands, got my supplies, and then I put the head of the bed up using a paper towel. So remember, this is going to be just a little bit different than the video you're about to see. Dignity is important. We need to put a towel over the patient's chest just in case stuff drips down. We don't want to get their clothing stained with toothpaste. We always wet a toothbrush before we put toothpaste on it. That helps spread the toothpaste around. It doesn't just glob up. Guys, when you're working with toothpaste on somebody else, a little dab is all you need. Now, I know that some of you grab your toothbrush and you put this great big, big stripe of toothpaste on there, but you're standing over a sink and all of that extra toothpaste will fall into the sink. Your patient is laying in bed. Don't overload the toothbrush. Little dab is all we need. Otherwise, they could actually choke because there's nowhere for it to go. Good? Make sense? Always wet your toothbrush first. We're just going to brush what they've got. Top, bottom, front, back, tongue. Let them rinse as often as they need to until they say they're done. They'll spit into the basin, and then we're going to use that towel that's on their chest to dry their mouth. This step right here is the most forgotten step for mouth care. Like half of everybody that does mouth care leaves the patient sitting in bed with a dripping wet mouth. How uncomfortable would that be for the patient? But you're focused on your steps. You're focused on you. If you can make that change, if you can flip your brain around and start looking at the patient instead of yourself, you will pass the test. You will. This won't fail you, but I think about it from the patient's point of view. Pretty crappy. All right, so here are our steps. Patient must be sitting fully upright. We're going to protect their clothing. We'll wet the toothbrush before we apply the toothpaste. We'll brush all surfaces and their tongue. We're going to let the patient rinse and spit as often as they need to until they say they're done. The more toothpaste you use, the longer you're going to be here rinsing. Okay? And then leave the patient's face and clothing dry. Any questions on mouth care? You guys all know how to brush teeth. It's learning to brush them on somebody else that makes it a little bit tricky.
So you said the CNA does warm-up. So if someone has mouth care and they're in like pain or they have toothaches or something, will the CNA do it or will the nurse do it?
Nurse would do it. Now, the nurse can give you additional training on how to do it, on that patient, but ultimately it's the CNA or the nurse's responsibility. Okay. I'll give you a great example of this. There was a patient that I took care of. The patient was a hospice patient. This was a horrible situation. Oh my gosh. So she was in an assisted living facility and wasn't able to perform her own mouth care. And she had mild dementia, right? But she had some, I think she had a stroke or some other progressive neuromuscular disease or something, but she wasn't able to brush her own teeth. Well, the CNAs weren't taking good care of her. And she was pocketing food up against her gum here. We have no idea how long it had been going on, but the CNAs weren't doing good mouth care on her. Well, that food decayed and it ate into her gum. Well, there's not much room between your gum and your sinuses. So it actually ate through her gum up into her palate and into her sinuses. So she had an open wound going into her sinuses. Now, can you imagine what toothpaste would feel like in your sinuses?
Oh.
So now it's definitely not a CNA mouth care situation. The nurse would have to do it because we're not using toothpaste. We're going to irrigate. It's going to be a whole thing. But what was, for me, the grossest part of it is that it was only discovered when it ate into her cheek. And you could see, we saw, basically, they waited until she had a hole in her face to discover it. So like Freddy Krueger type hole. You could see right in. You should not be able to see right into somebody's sinus from the outside. So this had been a very long-term neglect situation. And it turns out that the CNAs that worked on the day shift weren't brushing anybody's teeth. Yeah. They're like, no, that's gross. What did you think CNAs do? Did you go to class? So in that situation, the CNAs, if the patient wasn't agreeable for mouth care, what should the CNAs have done? Reported it to the nurse. If the CNAs were doing mouth care, they weren't doing a very good job of it. They definitely weren't watching. There was a horrible odor that nobody was investigating. I mean, there were so many failures here. But now mouth care is no longer a CNA skill for that patient because we don't want toothpaste up in the sinuses. Does that make sense? Oh, and that was just horrible. It ended up killing the lady. That's why she was on hospice. It ended up killing her because there is no space between your sinuses and your brain, guys. She ended up with an abscess. It ultimately killed her. So yeah, this is a really, it might be an icky skill, for CNAs, but it's a really important skill for patients. Good. Okay.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to do mouth care. Is that okay?
Yes.
Okay, I'm going to put the head of your bed up. And then I'll close the curtain, wash my hands, and gather my supplies.
Okay.
We'll
Now,
get you to
remember,
a
we would
full
wait
upright sitting
After
position
we got our
for
supplies to
safety.
do this.
And if I can get you to lean forward, please. There you go. Is that more comfortable?
Yes, much.
Okay, I'm going to close your curtain and wash my hands now. I'll gather my supplies. I'm going to start with a barrier, and we'll place that on your overbed table. I'm going to get a towel, a set of gloves, a basin, toothbrush and toothpaste, and a cup of water. We'll prepare the toothbrush first. We'll get it wet, place a little bit of toothpaste on it, and set it in the basin. Mr. Jones, can I place this towel over your chest?
Yes, please.
Okay. And now I'll apply my gloves. Okay, Mr. Jones, can you open wide for me? I'm going to brush the back on the bottom. The back on the top. And can you bring your teeth together? And stick your tongue out for me. Thank you. Set that aside. Go ahead and take a sip. Rinse your mouth. Let me wipe that off for you. Another sip.
No, thank you.
Okay. Now I'm going to dispose of my cup, wrapper, and toothbrush. I'll be right back. I'm going to remove the towel and place it into dirty linen. Going to go clean the basin, and I'll be right back.
Basin is clean like we clean everything else. We dump it, we rinse it, we set it down, pick it up with a paper towel, dry the inside, dry the outside, and then put it away. If you needed to disinfect it, you would do it while it's sitting in the sink.
I'll place the toothpaste in the basin, use the paper towel to open the drawer, and place the basin and toothpaste in the drawer. I'll clean up my work environment and go throw these items away. Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No,
A
thank you.
magazine?
No, thank you.
Okay, your call light is right here. If you should have any needs, let me know. Can I adjust the head of the bed for you?
No, this is great.
Okay, I'm going to open the curtain and go wash my hands. After washing my hands, I'll think about my skill, make any corrections I need to make, and then tell the evaluator my skill is done.
Okay. Any questions? Any questions? Yeah. It's just mouth hair. We all know how to brush teeth. There is a question up here about foot care I want to get back to real quick. It says, do we have to wash between the toes? This is from Anthea. And the answer is, for foot care, yes, you must wash between the toes and rinse between the toes and dry between the toes, but no lotion between the toes. Okay. All right. Any questions on any of the skills we've gone over so far?
Do we do anything with dentures?
We are going to learn how to clean dentures on Monday. That's a whole different skill. And yes, we do. All right. So let's go to the next skill we're going to learn, which is respirations. Oh, we already covered that. Let's see here. Yep, respirations, page 54. This is a documentation skill. It is actually the most assigned skill on the exam. So we'll get to that in just a second. So there's nothing new to learn here. We know how to do skill rules. We know the opening. We know to evaluate if we need gloves, and we know the closing. So the only thing we really need to learn here are the skill-specific steps. I have a video on this, although I'm going to do this one live. And here, I have a video on this. Down here shows you test-specific information. This skill should be able to be done in 5 minutes or less on a live testing student laying in bed. Charting is required. Normal respirations are between 12 and 20. And you can be off by 2 breaths in either direction and still be accurate. Okay. So, nothing new to learn. But let's talk about respirations. If you look at the care plan at the top of the page, it says patient will be lying in bed for this skill. Count the patient's respirations for 1 full minute and record your readings. How long are we counting for? 1 full minute. Why? Easy answer. Care plan said, if the care plan does not say 1 full minute to count, we can count for 15 seconds and multiply that by 4. It still gets us our full minute reading. But this care plan tells us specifically to count for 1 minute. So can we take that shortcut? No. If you take the shortcut, you fail because you didn't follow the care plan. Okay? All right. So we don't want to tell the patient that we're counting their breathing. If I tell you, okay, I'm going to count your breathing. Ready, set, go. Yeah. She stopped breathing. That's what happens. We then become aware of our breathing, which alters our breathing patterns. So we're not going to get an accurate measurement. So you don't want to tell the patient you're counting their respirations or counting their breathing or anything like that. Instead, we're going to use a very generic term like I'm taking your vital signs. So we're not lying to them. Respirations is a vital sign. We're not lying to them. but we're not going to help them hyperfixate on their breathing. Have you ever started paying attention to your breathing and then found you really couldn't stop? It's like once you start paying attention to your breathing, you're like all in it. And you have to get distracted by something else to stop paying attention. So we don't want to do that to our patient. Good? Make sense? Okay. So don't tell the patient you're counting their breathing. In and out is counted as one cycle. So it doesn't matter whether you start on the inhale to count, or you count the exhale, or you count the plateau in the middle. It doesn't matter. The whole thing is one. Okay? So if you start and the patient exhales, you count it because it's part of the whole. Good? Questions? In and out counts as one. So it doesn't matter where you start. So how long do we count? As long as care plan tells us to. This care plan tells us 1 full minute, so that's how long we'll count for. Guys, do you remember how long a minute was when you were taking a pulse? It was like forever. Yeah, this is even creepier for the patient. So when you're taking their respirations, you kind of need to let them know, hey, this is going to take me about a minute. I'll let you know when I'm done, but I will need you to remain quiet during this time. If you approach them like that, they're more likely to stay quiet. If you don't, if you just walk in, say, hey, I'm going to take your vital signs, is that all right? They say yes, you close curtain, wash hands, go to the bed, and you get a little awkward, isn't it? Your patient will start talking to you because they're feeling anxious. If you tell them, hey, this is going to take me a minute, I will need you to remain quiet, but I'll let you know as soon as I'm done, they will actually stop themselves from talking because they know it's going to take a full minute. There's nothing unusual going on here. They're not dying. It's planned. Everything is fine. But if you don't do that, your patient will start talking to you, or they'll start laughing, or usually they start asking, what's wrong? What's wrong with me? What are you doing? What's wrong? And that's not a question you can answer. Does that make sense? Let me tell you a little bit about vital signs real quick. Your patients, when you are taking vital signs, your patients will ask, what is it? They will. If you're taking somebody's blood pressure, they will automatically ask, what was it? If you're counting their pulse, they're going to ask, what was it? It's their vital signs. So let's say you're counting respirations and the patient says, what was it? And you say 24. Do you know what the next question they're going to ask is? What does that mean? Yeah, because they don't know. Is that okay? This is where we go off the rails because there is no answer to that question. You can't answer that question. Is that okay? What does that mean? If you answer that question, you are diagnosing the patient. You are drawing a conclusion. So you say, oh yeah, that's fine. And the nurse comes in 20 minutes later with a breathing treatment. And the patient says, what's that for? And she says, oh, well, your breathing's a little fast, so we want to slow it down. So I'm going to give you a breathing treatment. And the patient's going to say, yeah, but the other girl said it was fine. Do you see how that can play out to be a million different bad ways? So we have to be really careful when we're taking vital signs on a patient to try to sidestep the issue. When they say, what was it? Or what result did you get? Or how was my pulse? You want to try to sidestep that without giving them an answer, without being rude. So something like, I'm not sure. I just take it. I give it to the nurse. It's perfectly okay. Playing dumb is okay. You can also say, I'm sorry, I'm not allowed to give you that information, but the nurse would be happy to discuss it with you. I'm not qualified to make that determination. Any of those responses are good, but if you say, oh yeah, your pulse was 64 and your respirations were 20 and your blood pressure was 118/72, and they say, is that okay? If you answer that question, you're diagnosing the patient. You can't make that judgment. Because the next person that comes in and tells them something different, they're going to argue with. It's just the way it is. So be careful there. Okay? Does that make sense? Okay. All right. So what if the care plan doesn't tell us to count for 1 full minute? Well, shortcuts work. We're going to count for 15 seconds, multiply that by 4 to get our minute reading, and we're out of there in 15 seconds. Easy peasy. We like that. This is a documentation skill. So page 168 and 169 have your documentation forms on it. You can actually see a picture of it on the respirations page there. We just write the number that we got in that space. So it's respirations are pretty easy. But go back to page 27. Actually, what was it? 25. Go back to page. Yeah, 25. All right. So look on page 25. These are our testing care plan sets. These are the exact sets that the test gives you. How many of these clipboards have respirations on them? On page 25.
Like 5? 4 or 5.
Should be 4. What's that?
I just said red farms.
Yeah, that's a football analogy. All right. So out of the 11 potential skill sets that you might get, respirations is on 4 of them. So that means that this skill, you've got a pretty good likelihood of getting on the state exam. This is one you really need to practice. Good? Does that make sense? Pulse shows up, I think, on 3. But this is the number 1 skill. It's the number 1 most demonstrated skill. All right. So let's talk about documentation. This is on page 48. When you're documenting, there's something called the ABCs of documentation. ABCs means we need to be accurate, we need to be brief, and it needs to be complete. So we don't lie on documentation. It's a legal form. You only document what you did. So if you're coming on shift and another person is going off shift and you're getting a report from them, and that person says, oh man, I forgot to document this guy's vital signs. His respirations were 12. Can you go ahead and document that for me? Your answer is no. You do not document anything you did not do. Because if you document it, you are now taking responsibility for it. If that patient died 2 hours ago and that CNA has not been in the room to check on him and tells you, oh, document respirations, that means that you verified the patient was alive. Does that make sense? If you didn't do it, you don't document it. Your answer is, no, I'm sorry, I can't document for somebody else. You need to document that yourself. If you make a mistake, we put a line through it and we put error above it with our initials. We don't use whiteout. We don't scratch it out, and we never, ever destroy a medical record. There's actually a fine involved if you destroy a medical record. They will fine you. So be careful there, okay? Even if you're the only one that wrote on that paper, you can still be fined. So this goes over documentation principles, and you can read this, but the best time to document is when you do the step, the skill, whatever it is. If you wait until the end of your shift to document everything, you're going to forget something. You will. So the best time to document is when you do it. I'll tell you a documentation story with hospice. So there was a CNA at the bedside. The patient was actively dying, and the CNA's job was to ensure comfort of the patient. Turn them, reposition them, make sure that the family has access to them, that kind of thing. So the CNA is just sitting at the bedside with nothing much to do. And it was in the middle of the night, 2, 3 o'clock in the morning, and the CNA is trying really hard not to fall asleep. So she comes up with this idea, okay, instead of falling asleep, I'll just go ahead and chart out my 15-minute checks, because she had to check on the patient every 15 minutes and document that the patient was resting comfortably or, change position or whatever. So the CNA, to try to stay awake, just pre-documented. And about 4 o'clock in the morning, I get a phone call that the patient has passed. And I go to the house and I ask to see the notes because I want to make sure that the patient was comfortable and what their vital signs were, and that basically it was an expected, because there's an expected trajectory. Okay. And if their vital signs are all fine and then all of a sudden they're dead 10 minutes later, there's a problem. Right? Mm-hmm. So I get the notes, and the notes are charted up until 7 a.m. It's 5 o'clock. Patient's dead. And at 5:15, it says that they're resting comfortably. That is a legal form. I can't destroy it. So now I had to get it was a huge thing. Now we've got to get the supervisor involved. The medical examiner has to sign off on it because we don't know if there was foul play. We don't know. We can't make that determination. The only person that can is the medical examiner. So this is a hospice patient, but now we've got to call the medical examiner. All because the CNA documented before something happened. Now you try explaining that to a family. That's horrible. So be careful about doing things. And the CNA, I felt bad for her because she was just trying to stay awake. She didn't really understand what she was doing and how bad it actually was. She does now.
Were you the one who had to explain it to the family?
Oh, yeah. Yeah. I'm so sorry. I have to call the medical examiner. I can't declare this death. Because according to the records, the legal documentation, this person is still breathing. I can't declare a death at 5 a.m. if at 7 a.m. they're still breathing, according to the paper. And I can't destroy documentation. Does that make sense? So, yeah, she's no longer working for hospice. But I tell you these stories so that you don't make the same mistakes. Okay? Document when you do it, but never pre-document. Okay. Lying. All right. So there's a couple problems with respirations. It's the easiest skill to do. It really is. But there's a couple problems. Can I ask you to go lay in that bed, please? Yep. It's dead. Just got batteries. Oops, those batteries do not last long. Okay. So here is the problem. I'm just going to move your cup. Is that okay?
Yeah.
Here's the problem with respirations. Set that aside. Okay. Let's do this. Let's see if we can get Hollywood to help us out here. That'll work. All right. So here's the problem with respirations. How comfortable are you right now?
A little uncomfortable.
Yeah. It's a bit high on the creep meter. If you've got somebody laying in bed and you've got a complete stranger standing over them, not touching them, staring at their chest, pretty high on the creep meter. If I make her anxious, am I getting an accurate reading? No. So when we're doing this skill, we're going to make her think that we're taking her pulse. Okay, we're going to make her think we're taking her pulse. Now, to do that, I'm going to tell her I'm counting her vital signs, and then I'm going to hold her hand like I'm taking her pulse. But I don't actually have her pulse. I did not find, is her pulse down here? No, it's way up here. I'm not holding her. Does she know that? No. This is more comfortable, isn't it? Isn't that weird? Isn't that weird? This is a psychology principle that you aren't even aware that you have. And your patient isn't either. But just by holding their wrist, it'll put them more at ease. Does that make sense? Good? All right. So there is something that we can do to make this easier. If you guys all look at her tummy, you can probably see it going up and down. You should be able to see it on the screen going up and down, but it's kind of hard to see. Those of you at home that are playing along. But you guys at the table, you may be able to see her tummy go up and down as she's breathing. All you got to do is breathe. But there's a way that you can use psychology to make this a little bit easier. Can everybody see? All right, I'm just going to lay this here for just a second. Did that improve your ability to see it? You see it? So I did not change her breathing. What I changed was your ability to see her breathing. And that's by using a contrasting color, because our minds are drawn to movement when it's a contrasting color, because it may indicate danger. So this is a part of your brain that is very highly developed from back in the caveman days. And we're going to use it. So by putting an alcohol pad on her tummy, it's going to move as she breathes. And because it's a contrasting color, my eye is going to be drawn to it, which means I can count her respirations a whole lot easier. Does that make sense? Now, you can use this for the test. You can also use it in a clinical setting. There's nothing wrong with doing this. But you want to use an alcohol pad because they're mystical, magical, and medical. If I put anything else on her tummy, she's going to go, why? What is that there for? What are you using that for? She's going to be all confused and probably a little apprehensive. But alcohol pads, patients just assume you're going to use it for something in medical. They are comfortable with them. They don't ask. Patients don't ask. They just don't when you use an alcohol pad. And if they do, you can usually give them like oh, I'll need that later. And they're like, okay. They don't push it. If I put anything else on her tummy, she'll ask. and I don't want to draw attention to it. Does that make sense? So alcohol pads are good because they're disposable. They're cheap. We can throw it right away. But your patient will be accepting of it. Good? Questions? All right, remember in and out counts as one. So I'm going to do this whole skill from beginning to end. Now, it's not my first skill of the day. So that means the evaluator has told me I can simulate hand washing. So I'm going to do this whole skill and simulate hand washing just like it were your third skill. So when I put the alcohol pad on her tummy, okay, and I look at the clock and I say start, I want all of you to count the respirations until I say stop. Remember, in and out counts as one. It doesn't matter if we start on an in or an out. We're still going to count it. Good? Questions? And then after I'm done with the skill, I'll document it. I got to find a pen. I'll document it. And then we'll see if you guys got the same number I did. And remember, you can be off by 2 breaths in either direction from this. So let me grab a pen. Thank you. All right. Everybody ready? Here we go. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I need to get your vital signs. Is that okay? I'm going to close your curtain. Let me go wash my hands and I'll be right back. I'm going to close the curtain. I have clean hands. That's all I have to do. I have washed my hands. All right, Miss Jones, I'm just going to set this right there for a second. I'm going to be counting for 1 full minute, so I'll need you to remain quiet during that time, but I'll let you know as soon as I'm done, okay? Let me just have your wrist here. Can everybody see? Everybody good? Those of you way over there, you can come over a little closer if you need to. All right, ready, set, start. Stop. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Would you like a magazine before I go? Okay, she's dressed, bed's in the low position, environment's clean. Call light is right there under your hand. If you need anything at all, just let me know. I'm going to open the curtain. I would wash my hands. And I'm going to document in the respiration section, wash my hands again, and then tell the evaluator my skill is done. I got 21. 22? Okay, so if you got 19, 20, 21, 22, or 23, you're accurate. Pretty cool. Thank you. Her respirations were kind of hard to see. She isn't a big breather, so it's kind of hard to pick up. Go ahead and have a seat. So it's kind of hard to pick up. Anybody remember what I told you normal was? 12 to 20, and I got 21. So what would I have to do with that? Report it to the nurse because it's not what we call normal. 12 to 20.
backstory. I just got over having pneumonia, so
Oh my goodness.
there might be a little extra going on there.
Wow. Well, I'm glad that you got over that. You were probably a little bit nervous as well. That's what the nervousness is what I was going to talk about, because you are on camera in front of the class. You know, we're learning a new skill. All of that will raise the respiratory rate, but the pneumonia is definitely going to play into it as well. All right. Any questions on respirations? Any questions? Okay, we're going to switch gears. Okay, these are the test registration packets. It's a big packet that I'm going to give you. We're going to go over it all together. If you can take one and pass it down. Take one and pass one over to him. I think I gave you guys enough. Let me know if I need another one. I need one more, right? Thank you. Okay. So if you go onto my main website, foryourcna.com, looks like this. Under the testing tab, because that's what we're talking about now, is testing. So if you look across the top, you'll see CNA training, the online course, and testing, and then after certification, which we'll be going over on class 8. Right now, we're going to talk about testing. If you open that menu up, you'll see test registration instructions. It's also going to give you information on the background screening as well. So that's what we're going to go over here today. All right. So this paper that's on the front is our timeline. This tells us how this whole process works. So step 1 is to get the background check done. Some of you already have a background check, okay, through something, you know, daycare or concealed carry or whatever. You have a level 2 background. The problem is if it's not in medicine, it doesn't count. So if you worked at a daycare, that background check won't count. If you worked in financial services, that won't count. It has to be healthcare. About 8 years ago, Florida actually voted on this. And the whole premise was, let's do one background check container where if you get a background check, everybody else can access it and you don't have to go get 40 bazillion background checks. And Florida citizens said, no, I don't want to share my information. So medical can only share with medical now. Good? Make sense? All right. So the first thing we're going to do is our background check. And that's the first section we're going to get into now. So if you go to Prometric's website, now Prometric is our testing agency in Florida. That's who does the testing in Florida. Pull this around here so I can get to it. All right, so Prometric is who does testing in Florida. So if you go to prometric.com, Nurse Aid FL, it's going to bring up this page. This is for the Florida nursing exam. Other states that use Prometric, you would type in the same thing, except the last two would be your state. So TX for Texas, LA for Louisiana, CT for Connecticut, and so on. Under candidate resources, if you open that accordion up, this is what it's going to look like. And they actually have a fingerprint vendor list. So if you click on that, it brings up a whole list of all the background check providers in your area. You can actually search in your area and find one. There's a million of them. You can use whoever you want. Here in this county, this seems to be the best one for our purposes, and it's Deontis. It doesn't mean it's the only one. I know, Christine, were you the one that told me that your friend had did the background checks? Oh, Christine isn't here. Okay. All right. Somebody called me yesterday and said they had a friend who did background checks. I think it was Christine. Okay. You can go anywhere and have it done. The problem is you have to make sure that it's a level 2 with photo, and that's super important. If your background check doesn't have a photo attached, it won't be accepted, and you'll have to go do it again. So you want to make sure you get this right the first time. Does that make sense? So Deontis seems to be the best one for our purposes. They have a UPS store on Barclay that does the background checks. You don't have to pre-register. You can just walk in, but they're going to charge you an extra $25 if you just walk in. If you pre-register, it's a whole lot cheaper. So if you go onto Deontis's website, it's Daontis. It's on this page right there for you. If you go onto their website, there's 2 places. Up at the top, it says create an account, or at the bottom, it says register. Either one will bring you to this page. You want to create an account with your email and select a password. And these passwords are like the super hard ones because they have to have letters and capitals and numbers and symbols and all that kind of stuff. Once you've created your account and confirmed it, when you log in, it's going to take you to this page. And this is where everybody gets all messed up. I don't know what to choose here because it doesn't give you really any guidance. You want to choose Florida services. So you'll want to go back and watch this video again when you're ready to do your background check. So remember at 12:20. So 3 hours and 20 minutes into today's video will be the background check information. Okay. So we want to hit Florida services. And this code in the first column here that's shaded, there's a code there. This code is our ORI code. It's EDOH0380Z. You need this code because when you go on to Deontis and you click that Florida services, this is what's going to pop up and you have to put that code in. This is what tells, okay, we're getting a background check done, but this is what it's for and this is who it needs to go to. If you don't have the right ORI code in there, Prometric won't be able to find it. So once you do that, it's going to bring this up. It says CNA by exam. Yes, that is the right one. So we're going to hit next. And then it's going to take us to this page, which really messes everybody. If everybody gets to this part, this is when I start getting phone calls. So now, okay, we got the ORI number in there. That should be good. But now I've got this drop down that says reason for request. And there's firearms, volunteer, criminal justice, childcare, or other employment and licensing. So for us, it's going to be other employment and licensing. Okay, licensing. We're going to skip the OCA. We don't need that. Doesn't apply to us. That's like an employer identifier. We're not employed. And then we're going to fill out all of our personal information. Just whatever you need to put in there, name, address, social security, and so on and so forth. And then it's going to bring you to this, and it's going to ask you to put your zip code in to find a office close to you. You see that there's lots of offices in a lot of different places. When you put the zip code in, it's going to give us the hours of operation of that particular office, and it's going to give us the ability to make an appointment. You can usually make same day appointments. At worst, it would be tomorrow. So there's not a lot of wait involved in this. It's pretty quick. It's same day or next day. You'll put in your credit card information. For us right now, the total is $76.68. I have no idea when this is going to get changed, because everything is going up. So if they charge you something different, please let me know so I can amend this. But about $76 is what it'll cost you. When you go to your appointment, they're going to take fingerprints, a picture, and a signature. And then you go home. They're not going to give you anything. You don't get your background check. You just go to the appointment and go home or shopping or wherever you want to go. But they're not going to give you anything. You aren't going to send anything anywhere. That's what they do. This is all electronic. You can have zero input into the chain of custody. And that's because everybody has a cell phone that is capable of modifying a background check. I can take anybody's background check and give you a squeaky clean one. I have the skills. So I shouldn't have the access. Does that make sense? So you will have zero input in this. You go to the appointment and that's it. It then gets transmitted electronically where it needs to go. And that's why you need that ORI number. It goes to Prometric. Then once you've done the background check, about 24 hours later, you're ready to register for the exam. You can register online at prometric.com/nurseaid/FL. That's the quickest way. But you can also register using the packet that I gave you. Now we're going to go through this packet page by page so I can make sure that you have all the right things in all the right places and there is no delay in processing. If you register online, it is this exact application on the screen. So if we fill this out together, when you go home to fill this out online, you'll use this as your template. Okay? All right. So before we get started, this is where you find Prometric's contact number. It's in their sidebar. It has their address, their phone number, and their email. I want you to read this right here. This is on their website. If it has been more than 5 business days since you submitted an application and have not received confirmation, please reach us by phone or email. So when you register for the test, within 3 to 5 days, usually you will get an email back from Prometric that says, hey, we got your application. It's complete. We're now waiting on the Board of Nursing. If you don't get that letter within 7 days, you need to call them because there was a problem. Good? Makes sense? This is right on their, this isn't me. It's right on their website. Now, the problem is when you pick up the phone and you call them and you say, hey, Prometric, I submitted my application 10 days ago. I haven't heard anything back. I never got an email back. The person on the other end, their whole job is to get you to hang up. So they're going to tell you things like, yeah, it can take up to 60 days, or just give it a little while longer, or what does their website tell us? So that's what you tell them. Prometric's website says 5 days, I need a supervisor, please. You've got to get past that customer service person because this is the part you don't know. Prometric testing doesn't just do CNA testing. They do testing for construction, for IT, for human resources, for real estate, for, every industry. They have over 1,200 different testing that they do. So when you pick up the phone and you call, you're not getting a CNA person. You're getting a testing customer service person. So remember what their website says and use it against them. Okay? All right. So when we get onto Prometric's website, down under application, you'll see the online application form. Remember, it's exactly the same as what we're going to fill out together. Paper application is what you have in front of you, and this is what it looks like. So if you open this one up, you'll see a page that looks like this. The first thing that you see on that page is a stop sign. That stop sign says stop. Please make sure that your name is your name and you have 2 forms of ID that support it. So if you have a driver's license that has Daisy Hopkins Dukes on it, okay, and you have a credit card that says Daisy M Dukes on it, you cannot use those 2. They do not match. So you need 2 forms of ID that match. One has to have a photo, non-expired, like a driver's license, passport, military ID, and one has to have a signature, but 2 forms of ID. Below that, it asks if you need ADA accommodations, and then we get into our candidate information. So you can fill this part out on your own. I don't need to guide you through demographics. You're capable of doing that on your own. So past the demographics, let's go down here. Past the demographics, we get into this section. It says criminal and Medicare and Medicaid fraud questions. So this is where I need to help you out because this is complex. If you have a felony in your background, I need you to see me after class. If you have no felonies in your background, for number 1 and number 2, you're going to check no. Leave all of the other questions unchecked. So number 1, check no. Leave A, B, C, D, E unchecked. Go to 2 and check no. You only fill out the A, B, C, D, E's if you check yes on number 1. And you would only check yes on number 1 if you talk to me after class. So moving on to the next page, we have 3, 4, and 5. Now let me explain to you what this is asking because this is really complex, guys. If you have worked as a medical professional and you worked for a doctor or an office that committed Medicaid or Medicare fraud, and we do have some doctors in our county that were convicted of Medicaid and Medicare fraud. So I do have to go over this with you. If you worked for that doctor who was convicted of Medicare and Medicaid fraud, they would look at you to figure out how involved you were in the process. If they find you were involved, then they would have prosecuted you and you would be on a list of people that cannot work in medicine any further. Because if you know how to defraud the government, we don't want you in medicine defrauding the government. Does that make sense? If that does not apply to you, and this is a whole court thing that you would have to go to court, you would be notified you were put on the list, you would be found guilty, it would be a whole thing. You would know that this has happened. If that has happened to you, see me after class. If it has not happened to you, you're going to check no for 3, 4, and 5. Leave the A's and B's blank. Don't answer them. Moving on to disciplinary history. If anyone has been a medical professional in any way in Florida or any other state, you need to read these questions and answer them. If you have never been a medical professional anywhere, the answer is no all the way down. Right, for disciplinary. Basically, we want to make sure that you weren't a CNA in Indiana, knocked around some old people, got your license taken away, and you moved to Florida and thought you'd do it here. That's really what that's about. Okay. All right, moving on to criminal history. You're going to read these questions and answer them. It's a simple yes or no. If the answer is maybe, it's probably yes. So, do you have a criminal history? DUI does count, by the way. DUI does count. The second question there, by the way, let me go over that real quick. Second question is, do you have any records sealed or expunged? Basically, did you hide your criminal history? We will find it. 100%. Nothing is ever hidden. Yeah. That lawyer promised you. They lied. Imagine that, a lawyer lying. Shocking. The bottom one is juvie record. Do you have a juvie? We were all young and dumb, but not everybody got caught. All right. This next page, the health history. I am not allowed to help you with this section. You must read and answer each one of those on your own. You can do this on your own time so you can think about the answers and put your social security number there at the bottom. Now, remember this page on the front, right? Down here, I've got a line that's marked important and it's bolded. And it tells us that we must register as E3 challengers. Now, I've already done that for you. So on this page, you will see that I have already checked off E3 challenger. Do you guys see that? All right. Anybody here ever a nursing assistant in Florida previously and let your license lapse? Okay, everybody is then E3 challenger. Everybody. If you do this online and you check anything else off, you will not be allowed to test. And they'll eat your money. So what are you going to check? E3. Have somebody verify that you checked E3. Every single class, I have somebody that calls me up and says, I checked off E1 and they won't let me test. I know. They won't let you test. You have to check E3. Good. We are not a state-approved 120-hour program with clinicals. I cannot attest to your eligibility to test because we did not do clinicals. So if you check off E1 or E2, they are not going to let you test. And there's nothing I can do about that. So I'm trying to be very clear here. That's why I printed these off and already did it for you. Okay. Now, the section below that where it says test information, training information, we have an X through that because that doesn't apply to us. It only applies if you checked off E1 or E2. What did we check? E3. So it doesn't apply to us. So I've got an X through that so you don't try to fill it out. And then moving down a little further, we are going to test at a regional test site, a regional test site. So you want to put an X in that box, regional test site, or did I do that? I did that for you. Okay, but now we want to tell them where we want to test. So at the very front of this packet, these 2 pages, these are all the testing centers for Prometric CNA testing. This is it. I even put them in location for you. So if you look at Central Florida, at the bottom of the first page of listings, you'll see a Gillis International, the very last one. That is our closest testing center. So you probably want to put a star next to that. That is our closest testing center. And you want to make note of that particular code, the CNA TAMAIR, because it's by the airport, Tampa Airport. And we would put that in here, test site code. But you can test anywhere. If you want to test in Miami and jump on a cruise ship after to celebrate, you can do that. If you want to test in Tallahassee and go to a family in Louisiana afterwards, you can do that. You can test anywhere in Florida. Our closest one is Tampa, but that doesn't mean it's the only one you can choose. Anybody from Citrus County, there's 2 in Ocala. You may find that closer to you. Good? All right, and now we're getting down to the test fees. Let me go here. Oops. Let's go down to the testing fees. So the first one will work for most of you. The first one is just the normal plain Jane test, the one that everybody chooses, just the clinical skills and the written, because we have to take both to be certified. That's the one we're probably going to choose. But if English is not your first language, you may want earphones for the computer to read the test questions and answer choices to you. So if English is not your first language, or if you have a learning disability or a reading deficit, you may want the second choice, which is audio. Audio means the computer reads the test questions to you. Beyond that, the rest of those are more for retakes, except for the Spanish. Anybody here Spanish your first language? Okay, you can take the written test in Spanish if you want to. Now, you've done all your learning in English, so it might be a little confusing for you. But if you wanted to, you could take the written test in Spanish by choosing that. It's about 3/4 of the way down. Clinical skills in English and written in Spanish. Skills have to be done in English. There's no way around that. But the written test can be done in Spanish if you want. Also an audio version of that as well. So you're going to check off the choice that you want to make. They're all 155. And you're going to put 155 over in the column. And that's what we're going to pay. So first-time testers, the first one is usually what we choose. You can also have the computer read it to you. You can have it in Spanish. And our cost is $155. Now, we have to pay that when we register. So if you send this packet in, if you fill it out and mail this packet in, you want to, the last page is going to have our payment information. So you want to fill that out. If you're doing it online, there's going to be a place for payment information right online. So now we're getting to the last page here. It has an affidavit. You're checking this box, yes, that says that you have received these last 2 pages in the packet. This is their privacy policy, tells you how they're going to use your information. So I've included that for you so you can check yes, because you have received it. We're going to read these statements, sign and date. And then down here at the bottom, again, we're going to use the application against them. Down here at the bottom, it says if you do not receive your emailed ATT, that is authorization to test, within 7 to 10 business days, you need to contact them. So what does that mean? Let me explain to you the process. You get your background check done. It goes into the clearinghouse. You do your registration. It goes to Prometric. Prometric looks at your registration, goes and grabs your background check and puts it together in a packet. They send that packet to the Board of Nursing. This is an eyes-on event. It is not automated. A real live flesh and blood person has to look at your registration and your background to clear you for testing. So it's not automated. Once they clear you for testing, then they send it back to Prometric that says this person can test. We're approving it. Prometric will send you an email that says you're approved for testing. They will then send you an email with your test date and time. You don't get to choose. They test 7 days a week, 8 people a day. So when they send you a test date, let's say they send you a date of July 19th, and you're like, oh no, that doesn't, my sister's getting married that day. There's no way I can go. That doesn't work for me. You call up Prometric and you say, I can't make it on my test date. And while they're on the phone with you, they'll work out a mutually agreeable date. You don't want to wait on that. If you get your test date, you know it doesn't work, call them right away. If you wait until 5 days before you're scheduled to test, they're going to charge you, because they can't put somebody else in that spot. Does that make sense? And they're paying those evaluators. So if you cancel your test date within 5 days, they're going to charge you. Good? Make sense? If you are a no-show on testing date, they don't do refunds. That's on you. So don't skip it. Not unless you got lots of money. And if so, I like donations. So I know. We try to make it as affordable as we can. All right. So we're going to fill this out. We're going to sign date, and we're going to make sure that we understand the time requirement here. So if we have to call, we have ammunition. The last page is going to be your payment page. So you would fill that last page out if you're mailing in your application. Now, a couple things about the online. Application that's a little bit different from this. At the bottom of the online application, it has a question that they don't have on the paper one. And that question says, if you're going to send in supporting documentation, how are you going to send it? By mail or by fax? Doesn't matter which one you choose, check a box. I don't care. But what that is if you have a criminal history that they need more information on, how are you and they contact you, how do you plan on sending that? So it's not going to affect 99% of you guys. So it doesn't matter which box you check, but if you don't check a box, it doesn't submit. Okay, so make sure you check a box. The last thing that I need you to be aware of on the online registration. Now I've got a whole video on registering online, and all of this is in that video. I'm going to show you how to get to the video in a minute. But the last thing, at the end of the application, it's going to have a button to save and a button to submit. There is no button to save and submit. You either save or you submit. If you hit save, which I recommend, if you hit save, it wipes out your payment information when it reloads. So you have to put the payment information in again. Everything else will be there, but the payment will be wiped out. If you just go straight to submit and there's a glitch, you lose it all. Okay. So I do recommend saving it and then putting your payment information in and then submitting. Good. That messes students up all the time. All the time. All right. Remember, if it's been more than 5 business days since you submitted your application and you haven't heard anything back from Prometric, you need to call them. So after Prometric gets your application, your background check, they send it to the Board of Nursing and they get approval, you're going to get an email from them. Make sure you open all attachments, because that attachment will be where your test site is, the date and the time. Everybody's application is going to say the clinical skills at 9 and the written at 9:05. It doesn't mean you only have 5 minutes. It doesn't mean that. It just means you're scheduled for both parts on the same day. It's going to be pretty much an all-day event. Okay. So your homework for tonight or over the weekend is going to be, that is the wrong, 5 and 6. Don't look at the pictures. Chapters 5 and 6. 5 is on dementia. Pay attention to that chapter. You're going to have a lot of dementia patients in your career. Working with dementia patients can be very challenging. 6 is on skills. We cover skills in class. So don't worry too much about the skills. Don't read the step-by-step. We're going to cover that in class. But do read the paragraphs in between. Okay. Good. All right. Wrap-up emails will be coming to you. Let me get you your review sheet. Does anybody, hey, look at that. I actually got done on time. Does anybody have any questions for me?
It's up to us if we register it.
Yep. So that's a very good question. Oh yeah. Okay. So Christine is on here. Says, yes, my friend can come to the class. She takes a picture and brings everything for the medical background check. So Christine does have a friend or an acquaintance that does the background checks and can make an appointment to come in here and do everybody's if you wish. She's going to give her my contact information. I'll get in touch with her at some point and find out prices for you. And then I'll let you know next week. And then you guys can decide on a day if you want to do it here. Otherwise, you can do it through them. Doesn't really matter. Let me get your review sheets. So you guys are now officially half done. Half done with class. Has it been difficult for you? No? Yours is coming around. All right. Does anybody have any questions for me? Anything I can help you with? All right. So if you go to my main website, I don't have it on here. Let's see here. Hold on, I'm trying to find it for you. There it is. Okay, so if you go on to my main website, foryourcna.com, under testing, test registration instructions, this is where we started. This is a video where I actually do an online registration right on the screen. And I take you with me as I fill it out and talk to you about what to put where. So it's a great like follow me video. And then below it are slides. So I took every screenshot from that video and created a slide so that you can progress at your own pace. I would recommend that you watch the video all the way through and then use the slides for each step. And if you follow that, you should be fine on registering for the test. You can register at any time. You are ready. You probably feel like you need a little bit more practice, and you do. But starting next week, at the end of each class, we will have a little bit of practice time built right into class. First 2 weeks, I don't give you any practice time because you don't have enough under your belt yet. Starting next week, you will. So on Monday, we'll have probably about 20 minutes, 20 to 30 minutes. On Wednesday, we'll have probably about 45 to an hour. The following Monday, we'll have about an hour and a half. And Wednesday, we'll have about 2 hours. So from this point on, you have time in class to practice. You also have this room available from the time class ends until 4 o'clock while you're here, while you're enrolled. And then after graduation from 1:30 until 4 on Mondays and Wednesdays. So you have practice time. The piece of advice I would give you, don't put off registering for the test because you feel you're not ready. Trust me, you're ready. You don't have to trust you, trust me. And what ends up happening is that you don't register because you don't feel ready. You graduate, life gets in the way. A couple months later, you're like, oh my gosh, I still have to take that test, but now I can't remember. So you start watching videos and you're like, oh my gosh, I really need to practice, but I can't come to the practice room anymore. And you put it off and you put it off and you put it off. And before you know it, 2 years have gone by and you're sitting back in these chairs. I don't want to take any more of your money. Register for the test. You are ready. You don't have to have confidence in you. You need to have confidence in me. Okay? Trust me, you're ready. But that doesn't mean you shouldn't practice. Good?
So when do we start registering?
Today is good. Do your background check. But as soon as possible. If you register for the test now this weekend, you'll be testing a week or two after graduation, which is perfect timing because it gives you long enough to be able to practice, but not so long that you forget what I've told you.
So it does take a little second after you register.
3 to 4 weeks from the time that you register, which is why I do it on the halfway point. So most students take their test about a week or two after graduation. That's about when it's scheduled. Yeah, which is perfect timing. Okay, good. All right, have a fantastic weekend, guys. All right, those of you joining us online, have a great weekend. And I will see you guys on Monday. Until next time, happy caregiving.